We hope you will have a wonderful experience listening to all the talks which were lined up for you. Just to start off, and I pray Almighty that the whole program goes on well. I am Dr. Sanjay Reddy on behalf of ADA Primer, starting off the program in Hall B. Today, the first session between 2 to 3:05 is something in focus. In focus, we have 3 talks, and the chairpersons for this meeting are Dr. Dinesh Kamath and Dr. V. Shankar. They're one of the senior most physicians and diabetologists in Bangalore. They're great friends, and also been involved with the pandemic like nobody's business. They were the most sought after people, at least in the south of Bangalore here. So, can I get the CV of Dr. Shankar and Dr. Dinesh V. Kamath, please? Okay, I can introduce both of them. Dr. Shankar V is one of the senior most physicians and diabetologists in Bangalore, practices at Apollo Hospitals and runs his own center. He was also the past chairman of the Karnataka RSSDI, one of the most senior physicians in Bangalore. Another senior, along with Dr. Dinesh, is Dr. Dinesh V. Kamath. Dr. Kamath is also a physician diabetologist practicing at Apollo, having a center for diabetes and diabetes care at Malleshwaram. Also was the treasurer and vice president of the Karnataka RSSDI. Now I hand over the program to Dr. Shankar and Dr. Dinesh V. Kamath for the next one now, please. Over to you, chairpersons.
Dr. Reddy, 1 minute. I had a little problem with that sound. Who is the first speaker?
I think Dr. Anand Kumar Annamalai. I think Dr. Can we have the CV of Dr. Anand, please, and Dr.
Sarcopenia, yeah. Okay, thanks. Yeah.
So over to you, sir.
Good afternoon, and thank you for the entire team who was invited as a chairperson for this wonderful session. I congratulate them all, one and all. I invite Dr. Anand Kumar Annamalai, MD, Diploma in Diabetes, and MRCP UK, MPhil in Cambridge University, and FRCP in London. He is a consultant diabetes and endocrine specialist, Ashwin Hospital in Madurai. He is going to speak on the sedentarism and sarcopenia in the diabetic. So I invite Dr. Anand Kumar, please.
Thank you very much, sir. Thank you very much for the
Dr. Anand.
Start with thanking Sanjay Reddy for great comments. And in fact, I'm actually one of the opening batsmen. So this obviously means a lot, because basically this is a very important topic which is in focus, and it is a very important topic which is often ignored. So today I'm going to talk to you about sarcopenia and diabetes and its particular relevance with sedentarism, but also talk to you just generally about sarcopenia and diabetes and why this is particularly very important. So my conflicts of interest for this talk, none. So first of all, we need to define what really is sarcopenia and what it's related to diabetes. Now, sarcopenia is a loss in the skeletal muscle mass and also function. And with diabetes, it's implicated both as a cause and also a consequence. Now, altered glucose disposal due to a low muscle mass can occur, because it's important that glucose obviously is taken up in the muscle. The muscle has localized inflammation due to inter and intramuscular adipose tissue accumulation, which we'll talk about in a little bit more as we go on. And this results in the sarcopenia. So the criteria for sarcopenia. So how would you diagnose it? This is something which is often ignored. So we need to have someone with a low muscle mass. So this is a major criterion, and this has to be present. Now, along with this, you could have one of the other minor criteria. One of it is a low muscle strength, or you could have a low physical performance. So this is what is the typical criteria for sarcopenia. Remember, sometimes you could be fooled with people who have a high body mass index. Now, I was a big fan, and I still remain a big fan of Asterix and Obelix. So Obelix is obviously, is a person who's got a high BMI. You would think he's got a low muscle mass, but he's got a good muscle strength, and his physical performance is just excellent. So he clearly doesn't have any sarcopenia. So you would need to know this to understand sarcopenia. Now, how would you define it? Now, we all know body mass index. Now, that's a terminology which we use day in and day out with practice. Now, for sarcopenia, one of the important definitions is the muscle mass index. Now, how would you find out a muscle mass index? And you would do that by doing a whole body DEXA scan. And by doing a whole body DEXA scan, you look at particularly the appendicular fat-free mass, and you take that in kilograms. That's measured when you do a whole body DEXA scan, and you divide that by height in meters square. And that's similar to your BMI. You have the MMI, and you then look at where it is in the normal distribution. If basically it is between -1 to -2 standard deviation, these are people who are at risk for sarcopenia, and if it is very severe, it's less than -2. The other important aspect is the muscle strength, and this is assessed by the hand grip dynamometer. Now, this basically is a device which you basically pull, and then it measures how much you're able to how strong you are. And for sarcopenia, you need to have for men, women, it varies. Obviously, the strength level. A man with less than 26, less than 18. Aspect is the muscle function. Now, how do you assess the muscle function? The muscle function can be assessed by two tests. One is by the this for a period of acceleration for the first 2 minutes, and then
a lot of disturbance.
And their gait speed time. The other aspect is timed up and go. So you ask someone who's seen stand up, meters, turn around and come back to that chair and sit again. Basically 6 meters. You go forward, 3 meters forward, and then you turn around and then come back. Well, how would you define this? So, as with diabetes, you have lots of guidelines, you've got the Finnish guidelines, you've got the international working guidelines, and you have the. Now, I would.
Kamath, can you hear?
A lot of disturbance.
Dr. Anand, I think there's some background noise, and sir, I think both of you should mute your audio so that you can hear well. Sorry to interrupt. Go ahead, Anand.
I hope I'm audible, sir.
Yeah, now you are audible.
Okay. So, as far as sarcopenia definition is concerned, the Asian Working Group definition is particularly important. So, if you look at the dynamometer, as I mentioned, the hand grip strength, that assesses the muscle strength. And that basically a hand grip strength of less than 26 in men and less than 18 in women is a criteria. Now, if you look at basically the mass or basically the low muscle in terms of looking at a DEXA scan, you look at the muscle mass index, which I spoke about. Now, if you measure that for men, if it's less than 7 and if it's less than 5.4 in women, like their body mass index, then you classify them as having sarcopenia. And as far as physical performance is concerned, a gait speed of less than 0.8 meters per second in a 4 to 6 meter course is defined as sarcopenia. Now, this is important to understand when you're defining this, because that is an important aspect. Now, what are the causes? Now, the primary sarcopenia cause is age. So as you age, your muscles basically, are going to, become more wasted, and you're going to lose a lot of muscle cells. The other important aspect is always in relation to activity. So if you have a sedentary lifestyle, or let's say a person is bedridden or in a hospital, that basically is going to cause an acceleration of sarcopenia. The other important aspect is organ failure. Now, organ failure could include respiratory failure, renal failure, and liver failure. And you could also have associated inflammatory disease like rheumatoid arthritis or any forms of osteoarthritis. Malignancies can cause acceleration. Endocrine conditions, particularly with low testosterone, growth hormone deficiency, etc., can also cause this. Now, along with this, nutrition bears an important aspect. So these are the things we need to take into consideration when you're assessing it. So if you look at what markers, apart from activity and hormones, another major important aspect is the mitochondrial dysfunction in the muscle. Now, this leads to increased inflammatory markers, and whether that could be related primarily to what's happening in the muscle, or whether it is related to imbalance of hormones or imbalance of activity, all these are interconnected. So it is important to understand that this is a big cycle which is ongoing in the muscle, which has importance in terms of activity. Now, when we talk about the muscle, it's important we need to understand we're talking about the muscle, the adipose tissue, and also the bone. Now, all these are related. We know as we define that aging is going to cause sarcopenia. Nutritional aspects are going to cause also important aspects in sarcopenia, but nutritional aspects like overnutrition could result in obesity. And there's a crosstalk between the muscle and the fat cells. So if someone's having more than enough of let's say nutrition, there's a lipid infiltration and lipid toxicity, and this leads to inflammatory responses, mitochondrial dysfunction again, and leading to further insulin resistance in not only just the lipids, but that reflects on into the muscles also. And this would relate to excessive sarcopenia. Now, sarcopenia primarily per se also has its own problems. With aging, the protein synthesis comes down, the differentiation of the type 2 and the type 1 muscle fibers are altered, and this results in a decreased muscle mass. So sarcopenic obesity is an important entity which needs to be looked at. The other important aspect is the crosstalk between the muscle and the bone. Now, we know osteopenia and osteoporosis. These have been well defined and well characterized. Now, this entity of osteosarcopenia includes not only a decreased muscle mass and decreased muscle function, but also decreased bone mass. And again, both these go hand in hand. And apart from genetic factors and inactivity and aging, you have other comorbid functions and metabolic dysfunction, which should also contribute to this. These could also reflect in falls, fragility fractures, and they are independent markers of mortality. And obviously, these lead to disability. So as I mentioned, there's a crosstalk between the bone hormones, the osteokines, and the muscle hormones, the myokines. So you have a low sclerostin level, a low rank and Rankle level, and osteocalcium level can get increased in the osteokines, and particularly in the myokines, the myostatin is a negative regulator, and that is decreased. So all these actually accelerate the muscle loss and sarcopenia. So when we're talking about, aging and we're talking about loss of muscle cell, there are two important aspects to look at. So with a loss of mass, you get something called atrophy. But with sarcopenia, apart from a loss of muscle mass, you also get a loss of cell mass. And this results in sarcopenia. As far as type 2 diabetes is concerned, the prevalence is pretty variable. It can be from 7 to 29%, depending on the population studied. Now, muscle mass, there's a physiological change right from the 3rd to the 4th decade. Now, there's an 8% decrease every decade after 40 years, and there's a 15 to 25% a rapid increase after the 70th year. The same happens with muscle function, a physiological change, again, starting from age 40. There's a 10 to 15% decrease every decade, and after 70 years, again, there's a 25 to 40% decrease every decade. Now, this is a very, very interesting and important comparison of two particular people. On the left-hand side, this is a CT scan cross-section looking at the muscle distribution at the region of the mid-calf of two individuals who were 75 years of age with a body mass index of 35. Now, on the left-hand side, as I said, this is a person without diabetes. And you start with the outer circumference. And what you can see here is the subcutaneous fat tissue is minimal. You compare this on the right-hand side, the subcutaneous fat tissue is higher. This black mass is the muscular mass. And what you can find here is a decreased intramuscular infiltration by fat. And what you can see here on the right-hand side, if you look at the whole muscle mass on the left-hand side and you compare it on the right-hand side, the muscle mass has decreased. And along with that, you have an increased infiltration of fat cells inside. And that is what I was talking to you about, the interaction of the muscle, the fat, and also the bone. Now, all these three interact to result in in sarcopenia. Now, sarcopenia, as we spoke about in terms of what's happening at the molecular level, the mitochondrial oxidative stress, the mitochondrial apoptosis, the alteration of the mitochondrial dynamics, the hormones like myostatin, the inflammatory cytokines, all these basically have a huge impact on sarcopenia. Now, muscle, as far as diabetes is concerned, it's the largest insulin-sensitive tissue, and it's going to take up glucose through the receptors. Now, a low muscle mass would mean a less glucose disposal, and a muscle fat infiltration would mean more insulin resistance. So in relation to this, a sarcopenia that could increase diabetes risk per se in people without diabetes, and diabetes can increase sarcopenia risk by itself. So both are interlinked. Now, this is a fantastic physiological study. It was looking at influence of age and skeletal muscle mass over a period of time in people from 15 years to 85 years. So we do know that there is a decrease in the muscle mass as we spoke about. And the approximate decrease in terms of mass is 2 kilograms per decade in men, and 1 kilogram per decade in ladies. Now, what happens if you had a 10-day of bed rest, so inactivity, in someone who's old? So when we say old, greater than 70. So when you looked at the DEXA scan, the whole body change as far as the appendicular lean mass is concerned was as high as minus 1.5. So a minus 1.5 kilograms over a period of just 10 days was a change. Now, and particularly so in the lower extremity, it was as close to the greatest, which is close to 1 kilogram. Now, as far as the muscle strength again, the percentage change was decrease of up to 15%. So if you come back to this, if you were to compare it, so what happens in a decade happens in 10 days of bed rest in old subjects and 30 days of bed rest in young subjects. So you can see inactivity, what this could lead to in terms of sarcopenia. Another important aspect is the protein intake in sarcopenia. Now, protein intake is very vital. Now, if someone's not taking adequate protein, and if you particularly look at our population with predominantly a high carbohydrate content and a less protein content, you have increased sarcopenia. Now, again, here, if you can look at this particular figure, you can look at people who had the lowest quintile of protein intake was associated with a greater decrease of lean body mass. So muscle mass came down, and the highest was the lowest. So low protein intake means a higher risk of sarcopenia. Now, looking at type 2 diabetes, there are lots of studies which actually looked into this, but I'm just going to quote a few just to kind of make my point. So this is a cross-sectional study, an observational study which was published just last year, looking at sarcopenia. And what it observed was that sarcopenia was much higher in people with type 2 diabetes in comparison to the general population. General population with aging, it does happen, but aging and diabetes, or just diabetes per se, increases the risk of sarcopenia. And again, as a crosstalk we were talking about between the muscle and the bone, if you have osteoporosis, the risk of sarcopenia goes up 3.5 times higher. If you have complications like diabetic nephropathy, chronic kidney disease, and albuminuria, again, this can go up to 3 times. Now, again, the male and female, there is a little bit of difference again. Females basically have more risk of osteoporosis. They're probably more prone for this. Now, the percentage of total fat, again, has an importance. Now, we were talking about fat distribution. If basically the fat, as in you had more obesity, again, the interaction of fat and the muscle, the fat mass was more, you had more muscle loss. This was a Chinese study which looked just not at sarcopenia, but also the pre-sarcopenia, again, defined by the whole body DEXA scans looking at the free fat mass. Sarcopenia, again, was much more prevalent in people with type 2 diabetes compared to people who weren't. And pre-sarcopenia was as high as twice the ones without. And this was particularly in people not just with greater than 70, but also between 60 to 70. And further studies have shown that happen even at younger ages. This important trial looked at a mortality rate. Now, sarcopenia, this is an important marker for mortality. Now, out of diabetes, someone having sarcopenia, it is a marker for mortality. Now, if someone has type 2 diabetes and has sarcopenia, does this reflect an increased mortality? Now, this was a 2-year mortality study after someone who was admitted in hospital and discharged, and they were followed up for a period of 2 years. And what this showed is, compared to people who did not have sarcopenia, the people with sarcopenia were at higher risk of mortality, and the people with type 2 diabetes and sarcopenia, the risk of dying was higher. And so this clearly is a very important aspect which we need to take into consideration. This is a marker. Now, would it reflect, as in you improve the sarcopenia, does it reflect onto longevity? We don't have trials looking at that, but this is an important aspect. So type 2 diabetes with sarcopenia, the chances of dying are higher. It's like the hazard ratio is like 1.61. Now, this brings us to the question of this inactivity, which is, particularly the topic which basically, we're going to deal with. Now, during the COVID-19 lockdown restrictions, huge aspects of, were basically affected in terms of not just disease processes, but also in terms of activity. So people were inactive. This cartoon, I love this, is just SpongeBob sitting in front of the television. It's in the middle of the night, just watching TV, doing nothing, and just spending their entire time just doing this. Now, this is an important aspect. So this lifestyle behavior of decreased physical activity, decreased step count time, increased screen time, and along with this increased stress and anxiety and decreased sleep quality, watching TV, looking at your cellular phones, very stressed, decreased sun exposure, very refined food, snacking, less protein, all these with increased time at home had a bad impact. This impact was on the muscle. The muscle, basically was lost, more adipose tissue accumulation. So from sarcopenia, the sarcopenic obesity, increased inflammatory cytokines, oxidative stress, increased cortisol, pro-inflammatory cytokines, low vitamin D, decreased anabolic hormones, a big mess. And what this result in? Long-term health risks. Now, apart from, getting COVID, you had this just by sitting at home. The cardiovascular disease risk increased, disease risk increased. If you had diabetes, it got worse. Osteoporosis and fractures got worse. Cognitive decline and depression, physical frailty, quality of life, everything got affected. So this is very, very important to understand. Now, a lot of things you could counteract. We'll talk about this a little bit later again, but, physical activity, at home, it was suggested, you could do household chores, resistant exercises. The diet quality could be improved by a high quality protein meal. You could have, you should stop taking processed food. You have whole unprocessed food, walking at home, a lot of things along with supplements like vitamin D. But, again, there was a group of people who said, okay, I'm not going to be inactive, but I'm going to be very active, decrease my calories, try to get my weight down, and, but still continue the bad habits of, not sleeping well, sitting in front of the TV or sitting in front of their mobile phones. And this then showed that basically had a calorie restriction and had restricted sleep. They lost more of basically the fat-free mass. So these were people who had calorie restriction, they were losing weight, but still they lost more of their muscle rather than their fat. So if you look at cross comparisons in type 2 diabetes and sarcopenia, now if you have age, clearly increasing age, these are various studies looking at age and type 2 diabetes, increasing age, more sarcopenia. Body mass index, it was pretty variable, but the higher the BMI, yes, basically it looked like the sarcopenia was better, but as I mentioned earlier, the higher the fat, the sarcopenia and the sarcopenic obesity was higher. This is duration of diabetes. The more the duration of diabetes, the more is the risk of sarcopenia. And HbA1c is variable, but generally a poor glycemic control meant a worsening of sarcopenia. This basically was another interesting Japanese study, which looked at people with type 2 diabetes and a low muscle mass and looked at whether a population with a low BMI did the HbA1c correlate. And it did show that in a BMI between 23 to 25, a higher HbA1c increased the risk of sarcopenia. Now, this was in comparison to a normal population where the HbA1cs are between 5 to 6.5. This included the IGT population, comparison to people with type 2 diabetes. So someone with a high HbA1c with diabetes, it will increase the risk of sarcopenia. What about medications? So medications, it's pretty variable. In general, it looks like metformin probably has an improved impact on sarcopenia, but again, we don't have very strong studies in terms of nailing it and saying that this is what happens. Sulfonylureas, especially with glibenclamides and meglitides, have shown that actually the sarcopenia gets worse, but again, certain studies don't show it. But it's very variable. One concern always is people who are taking SGLT2 inhibitors and thiazolidinediones, whether there is an alteration. Again, the body weight, although it changes, the muscle mass basically it's still pretty unclear, and generally it actually doesn't have a huge impact. But clearly there is a variable response with drugs. And these are the
we are running out of time.
So this is common, and this is sulfonylurea, thiazolidinedione, and GLP. So as far as management, avoid sedentarism, adequate sleep and stress-free, combining resistance and aerobic training with diet-induced weight loss. Protein intake has to go up not just by 0.8 to 1 by 1.2 to 1.6 kilogram per day, adequate vitamin D intake, and an optimal glycemic control. So to conclude, sarcopenia is an underestimated aspect of diabetes, which is linked to age predominantly, but inactivity plays a huge role. Diet, and especially with diabetes, the duration and control have important aspects. Sarcopenia, obesity, and osteoporosis are interlinked. Association of sarcopenia with mortality and diabetes complications exist. And it is important to understand that lifestyle measures, specifically exercise, aerobic and resistance exercise, adequate protein intake, and good glycemic control have a major role in sarcopenia. I'll probably end there and just say that the journey of 1,000 miles begins with a single step. Whether it is for anything, including sedentarism and sarcopenia, it's a huge, important aspect. So, thank you very much.
Very good presentation about this muscle mass in the diabetes. I have one or two questions about this. So do you do a muscle biopsy for all these patients? Because,
Shankar, can we take the questions in the end, please?
Oh, is it? Because I have a meeting.
We have time, sir. We have discussion time in the end.
Okay, fine. Thank you. So the next speaker, I'll invite, thank you, Dr. Anand Kumar, Dr. Chaitra Selvam. Very good, I think it's a very interesting topic at this pandemicity. The anxiety, the new pandemicity and its impact on diabetes and management. Dr. Chaitra Selvam, MD, DM Endocrinology, MRCP UK. She is a senior resident and associate professor, Department of Endocrinology, Ramaya Hospital, Bangalore. So I welcome Dr. Chaitra Selvam. Please, you can take up. Thank you very much.
Thank you so much for the kind invite, sir. Very good afternoon to everybody. And my gratitude to Dr. Krishna Seshadri and Dr. Sanjay Reddy and Team Primer for giving me this opportunity. While I begin sharing my screen, I hope everybody in the audience is doing well and you and your family are safe. Why are we suddenly talking about anxiety and diabetes? I think we all know the answer, but maybe we should pause and reflect on the potential interactions and how it might be affecting clinical practice for us and also for outcomes for people who come to us seeking help. So of the many mental health issues that plagues the world, on top of it all is anxiety disorder. It's the most prevalent mental health condition globally. And if you're trying to look at national evidence, this is a chart which is trying to look at the prevalence of depression on the right side first panel. The second panel is looking at anxiety disorder, that it is a prevalent condition. The darker shades of red and orange indicate greater prevalence per 1 lakh people. And you do see that depression and anxiety exist, quite strangely, maybe more in the southern states than the rest of India. But this is data which is over 2 to 3 decades, and underreporting could potentially be something which is offsetting the reports itself. So this is to highlight that mental health disorders are not uncommon in India. It's not a first world problem alone. It's probably not being recognized as much. That's the point I'm trying to make. But what's the connection with diabetes? We're all aware that type 2 diabetes is an extremely prevalent condition. We also know that individuals who have been diagnosed with diabetes do tend to have greater prevalence of clinical symptoms of anxiety or even subclinical symptoms, what is now probably referred to as diabetes distress. We also know that individuals who have coexisting anxiety are more likely to have poor metabolic outcomes and greater risk of complications in the long run. And if you're trying to look at the prevalence of anxiety in individuals with diabetes, the range is between 14 to 55%. What that essentially means is for every 5 patients you see in your clinic, about 3 to 1 person in your practice today could potentially be having anxiety, which could be getting in the way of management of diabetes. And so thereby it becomes our business to care about. And the pandemic has not helped the mental health situation at all. The lockdown has not helped much. The economic changes which have happened in our lives is not helping the situation. And we are now seeing that more and more mental health crisis is happening amongst patients, also amongst doctors, right? So if you're trying to look at the prevalence of anxiety disorder pre and post-COVID, this is one such survey which was done with the guidance of the CDC team, which is the Household Pulse Survey. It was an online survey which was done to find out how many adults reported symptoms suggestive of anxiety or depression. And you see that it has increased 3-folds since the onset of the pandemic. No surprise there, right? But if you try and break it up to see what is anxiety more, is it depressive disorders more, you do see that anxiety is reported about 35% of times versus depression being reported about 28% of times. And if you break the people who answered the survey age-wise, you see that about 56% in this particular survey were people who were between the age of 18 to 24. So probably the inference from this is that no age is spared, old or young, all of us are plagued by anxiety post-COVID. The many reasons for that is the obvious fear that of illness, of loss, of us, of our dear ones. Also, the non-stop infodemic by media is not helping. Also, the economic changes secondary to maybe lockdown, or changes which have happened in the world secondary to pandemic not helping at all. But if you're trying to understand the interaction between blood glycemia, blood sugar control, and anxiety, probably we need to go back a little bit to physiology and try and understand that anxiety, yes, could increase the risk of greater release of counter-regulatory hormones like glucagon and epinephrine. If you're in a state of a chronic stress, it could potentially increase blood glucose levels by increasing catabolism like ketosis and lipolysis, and which could potentially worsen diabetes itself. But if you're trying to look at the relationship between anxiety and type 2 diabetes the other way around, we do know that the diagnosis of diabetes can bring on new onset anxiety in individuals who've not had anxiety before. And managing diabetes, especially if you're on multiple dose insulin, is not an easy task at all. And it could lead to quite a bit of anxiety just to juggle the whole management itself. But there are numerous pathogenic factors which could be common between the two. So there is some evidence to suggest that not having a regular routine for a day, not prioritizing sleep could be a risk factor for both diabetes and anxiety. We do know that unhealthy eating, sedentary lifestyle also could increase the risk of both the conditions. Also, some evidence to suggest that there could be shared genetic predisposition between the two conditions itself. But why should we, as endocrinologists and diabetologists, be concerned? I think you have an inkling of an idea, but I think we all probably need evidence to convince ourselves that we need to probably start caring about this a little bit more. There is evidence to suggest that diagnosis of anxiety in a person does increase their risk of not adhering to treatment completely. It's also associated with higher risk of diabetes-related complications. And also probably self-care regimens are likely to be not consistent in individuals who have anxiety. It's also been known to have increased risk of complications, increased BMI, decreased quality of life, and worries like that. And this was a study which was done a little while longer, 2011, not anything recent, which did show that amongst individuals who had anxiety without anxiety, people who had anxiety had poorer glycemic control, greater BMI, and lesser scores on physical activity per day to fight sarcopenia. And they also are people who have increased risk of mortality. So if you're trying to look at the four graphs, the solid bar is none of the illnesses. The next line is anxiety alone. Then the third line is type 2 diabetes alone. And the fourth line is where you have anxiety with type 2 diabetes. Of course, individuals with anxiety do have increased mortality, but individuals who have diabetes and anxiety have increased risk of mortality itself. It also correlates strongly with low markings on quality of life when you have coexisting anxiety. And this is now new data. What was now speculation is now confirmed. This is data to show that with the onset of the lockdown and COVID, in individuals who had type 1 and type 2 diabetes, there was a worsening of HbA1c, which was noted, right? So yes, it is affecting individuals' glycemic care. So thereby it becomes something that we need to probably address and care about. Now, screening methods are numerous, and I know OPDs are busy. We don't have enough staff around, but how do you go about making sure that you don't miss individuals who probably will do best by seeking for some help? And at least in India, we've not made it very easy to talk about mental health amongst colleagues, amongst patients, with everybody else. But before we delve into diagnosing anxiety itself, it's probably important to remember that it could potentially have certain symptoms which could overlap with symptoms like hypoglycemic episodes. And probably another differential that you should consider is a cardiac event, right? So sweating, discomfort in the chest could also mean a cardiac event, especially in women who are more likely to have atypical presentation of coronary artery disease. So don't just brand it as anxiety because it's post-COVID world. Please do get an EKG and evaluate accordingly if required before we make a diagnosis of anxiety itself, right? And there are numerous scores which are available, which are easy to administer if you have a support staff who will remember to hand it out to your patient before they walk into your clinic, because it takes some time and thought for you to sit down to think about it and mark it. And also a certain amount of an open communication with your doctor to feel comfortable to share everything that you're feeling. but they take about 3 to 5 minutes to fill out and are fairly well designed for you to get a picture as to is your patient having more anxiety or more depression. And this is one of them. This is the diabetes anxiety depression score. There are numerous other scores, the WHO 5 well-being score, the problem areas in diabetes score, the patient health questionnaire score, the hospital anxiety and depression scale. All of them do a fair job of identifying people who are susceptible. Probably the constraint is having somebody who will administer it consistently and somebody who will interpret it and then act on it. But what should your motivation be for screening? That there is enough evidence to suggest that our patients are likely to do better when we address their mental health comprehensively along with metabolic health. So that should again push us. But does ADA recommend we do everything that ADA recommends? Does ADA recommend screening for anxiety in individuals with diabetes? Yes, the ADA does recommend that. It has been recommending it for a while now, but it's something that we're probably not finding enough time to address in our clinic. It does say that you must ask 1 or 2 questions to look for anxiety in individuals with diabetes. But of course, I don't have enough time. I have my own anxiety to deal with when there are 20 patients waiting in the OPD. I don't have support staff to interpret the questionnaires. What should I do moving forward? So probably we can have our own methods of finding out how our patients are doing. If you're seeing somebody for a long time, I think you will be able to say when they're not feeling okay, like our patients are able to say when we're not doing okay. So maybe start by just asking, how are you doing, right? So if they say it's been tough, and I'm struggling, acknowledge the struggle. And that shows that they are struggling. Ask them an open-ended question saying, do you think we should seek help to tide through what you're going through? And if at this point they've been struggling with anxiety and depression, which probably needs medical assistance, this is when the floodgates will open, or they will definitely let you know that they seek help. Now, this might not be a foolproof method, but it works most times. So a simple question saying, how was your sleep? Or in native language, man kaisa hai? Or how is your mood doing? Should be enough to get you an answer. And once they let you know that they are not doing okay, we don't have to know everything to solve their current mental health situation. All we need to do is put them onto somebody who will be able to help them through. I think one of the things that holds us back from asking these questions is we don't know what to do when they start crying. We don't know what to do when they say, yes, I'm having this and this. I think we should be okay to put them on to a person who's equipped to help them through it. So have a psychologist who have a rapport with, who will take care of your patient and put them on to them, and maybe a psychiatrist as well, if the psychologist thinks that they will probably need pharmacotherapy. So this is just COVID and pandemic, and we're talking about anxiety. Does that mean post-COVID we'll forget about anxiety? I think this is a snapshot of the various, let's say, triggers or points where you can have mental health disturbances. So any major life transition, and this is one of those life transition moments for all of us, could potentially be a precipitating factor for mental health instability. Similarly, let us say when you detect retinopathy for the first time could be a potential time, or for the first time when you notice that the creatinine is rising. So be aware of vulnerable windows and make sure you're checking in with your patient and finding out how they're doing. I'm not really going to go into treatment because this is not my area, but the general principle of treatment is this. If they're able to have a good score on their, the health questionnaire, where they're able to indulge in self-care well, you could just refer them on to a coach or an educator or a psychotherapist, and that should help. But if you're noticing that self-care is dropping, wherein diabetes care also drops, and they score high on their general anxiety disorder questionnaire, that's probably when you probably need to pick up the phone and call your psychologist and make sure that you directly transfer care onto them, right? So this is something that we should be aware of and probably start doing. If you're wondering about the impact of the medications which are used to treat anxiety on glycemic control, And this is whether it is SSRI or whether it is psychotherapy or whether it is collaborative treatment or whether it is tricyclic antidepressants. The overall summary of the impact of all of these medications on glycemic control is that glycemic control improves, right? So which essentially means that it does get in the way of hyperglycemia management. So quickly to summarize, and this is my last two slides, diabetes mellitus is a chronic condition which is not very easy to tackle or deal for a non-medical person. So there is increased likelihood of anxiety disorder and anxiety symptoms. The current COVID situation has not helped us at all. So presence of chronic anxiety could worsen hyperglycemia, diabetes as a diagnosis, as well as additional comorbidities which get added to the list of diagnosis could potentially have many vulnerable windows where mental health could go for a toss. It directly impacts the outcomes that we are taking care for our patients in terms of worsening complication risk or worsening all-cause mortality or quality of life. Thereby, if your intention is to provide comprehensive care, screening for mental health well-being is definitely recommended. So just a simple questionnaire, if you can find a small questionnaire which you can regularly administer, or maybe a parting question at the end of the summary while you're wrapping up, is a good way to find out how they are doing and hand them over to somebody who can help them, even if you're not able to provide all the solutions that you should for mental health issues. So that's the end of my talk, and I hand back over to the chairpersons. Thank you.
Thank you, Dr. Chitra Selvan. It was a very wonderful and comprehensive talk, which is the most neglected part in our diabetic practice, because physicians are so busy with the number of cases. I think they'll not have much time to go into all these details. At least you have given some clue and some hints how to pick them up and, if required, refer them to the suitable people. Thank you very much. We'll go to the next talk. The next topic is getting the exercise prescription right. Is walking sufficient? Even this is related to our global pandemic. Here we have Dr. Neeta Deshpande, who is the director and consultant at Belgaum Diabetes Center, Children's Diabetic Center in Belgaum. She is well known in Karnataka. She's been talking in various forums and very close to us. She was also the chairman of KRSSDA in the past. Over to Dr. Neeta.
Thank you so much, Dr. Kamath. At the outset, thank you, Primo, for giving me this opportunity to speak on this very, very interesting topic. So before I share my slides, briefly, I would like to say that everyone needs exercise, more so people with metabolic complications. And anyone who walks into your office, if he asks what kind of exercise should I do, or if you ask him or her what you're doing, you're most likely to get the answer, I walk 30 minutes or I walk 60 minutes. Do you do anything else? Maybe just a little bit of yoga here and there, but basically it's walking. So let's see now whether that is really sufficient in times to come. So I will share my screen now. Yes. So getting the exercise prescription right is what I'm going to talk about, and is walking really sufficient? So I would like to say here that walking is important, but is it sufficient? So I do not have any disclosures for this talk. However, I would like to acknowledge that some of my slides have been given to me personally by Dr. Sri Kumaran Nair, and I'm going to show some of them from Mayo Clinic. Well, all of us know, but I'm going to reiterate just so that you have a perfect idea of what an ideal prescription for exercise should actually look like. You have here aerobic exercise. And in this, you have repeated and continuous movements of large muscle groups. And this is where your walking features. So you can see here that this first part of aerobic, which is there, walking features here. But what you're missing out on if you do only walking are these two very important parameters. And these are resistance training and flexibility and balance. Now, resistance training basically prevents sarcopenia, and you do that with the help of free weights weight machines or your own body weight for that matter, or you use elastic resistance bands. It can be done in various ways. And as you can see here, you don't really have to hit the gym. You can do it on your own. And the third category is flexibility and balance, which is extremely important because it improves the range of motion around joints and benefits gait and prevents falls. So as time goes by, as we get older and older, these issues become very, very important, and they should be included in the exercise right from the beginning. And yoga and Tai Chi are good examples of both flexibility and balance, which can be offered by this type of exercise. So basically, in a nutshell, these are the three types of physical activity, and walking covers only the aerobic part and not the other two, which I have shown you over here. Now, this is the hierarchy of different exercises if you wish to burn fat, and that is what we all want. We want our muscle mass to stay where it is or improve if possible, and we want fat to go away. So if you had to do that, these different exercises that you see here, in terms of intensity and time required, you can see that they are actually inversely proportional. And walking features somewhere over here. So you require a lot of walking, okay, to get fat loss, and that may not be possible. And you can see that resistance training is right here in the center, and you have circuit training, which I'm also going to refer to a little later, which is right here at the bottom, which means that it is high intensity, no doubt, but very little time is required. And today we all know that time is at a premium, and that is why you will get different kinds of patients who say they don't have the time to do much of exercise, because if they had to burn fat with walking, they would have to do a whole lot of it. So this is how it is spread out in terms of fat burning as an exercise. So clearly, why walking is not sufficient, it is not sufficient, is what I'm going to tell you in the next couple of slides. But to know that why walking is not sufficient, you need to know a little about the effects of aging. What happens once you start aging? You get sarcopenia. I know you've heard about sarcopenia in one of the lectures just before this, but basically it involves all the striated muscles, including the respiratory muscles, and is the main cause of fragility and dependence on others as time goes by, and is responsible for falls and fractures. And it has nutritional implications, and it is associated with a whole lot of metabolic problems. So that is why we have to tackle sarcopenia, and clearly just walking is not going to tackle sarcopenia. And just to reiterate further, this is an excellent study done in the Mayo Clinic itself, where this is thigh muscle area and this is the knee extensor strength. And you can see here that as a person ages, you can see that the muscle mass keeps on reducing, both for men and women in both these muscle groups studied. So this is a very important study to tell us that as you age, your muscle mass is going to get compromised, and you have to try and limit that to whatever extent possible with the right kind of exercise. So just to show you pictorially, this is the picture, the skeletal muscle mass of a young person versus that of an old person. Look at what has happened to the muscle mass. So this is how it reduces, and this is how you transition from being young to being old in terms of skeletal muscle mass. And when this happens, what you're going to have is reduced muscle mass, reduced muscle strength, number of muscle fibers are going to reduce, etc., etc. And muscle protein synthesis itself is going to be much less, and hence the mitochondrial function. And this is what is responsible for the various metabolic problems that can come about. So you can see here that this is, if you want to prevent the transition from here to here to whatever extent is possible, then clearly walking is not sufficient. You need to get these muscles in place. You need to limit the sarcopenia. You need to limit this entire process that you are seeing up here on the screen. And for that, you require a good regimen or a good exercise prescription that clearly does not have only walking. It has much more. And therein lies the importance of resistance training. So along with walking, resistance training is also very important. And how does that work? What resistance training does is it causes microscopic damage or tears to the muscle cells, which then are quickly repaired by the body to help the muscles regenerate and in the process grow stronger. So you actually damage it and then make it grow. The muscles heal once you have done that. Once you've done one bout of resistance training and you have caused this microscopic damage, then the muscles begin to heal and they begin to grow between the workouts, not at the time that you're doing the resistance training, but between the workouts it is given. And that is why you need a period of recovery. We always say do not do resistance training for the same groups of muscles on 2 consecutive days, because this is the basis that you need time for the muscles to grow. So you have to give a day's at least 24 hours in between. This is a study that tells you about resistance training in type 2 diabetes in older adults. Why have I picked this study? It is because everyone says that we are quite old. Can we really do resistance training at this point of time? So this is a study which tells us very nicely. It's a randomized controlled trial examining the effects of progressive resistance training on insulin resistance and body composition in older adults. There were 103 participants and they either received resistance training or sham exercise 3 days a week for a whole year. And HOMA-2IR and A1C were used as indices of insulin resistance and glucose homeostasis. And skeletal muscle mass and total fat mass were assessed using bioelectrical impedance. Visceral adipose tissue, mid-thigh cross-sectional area, and mid-thigh muscle attenuation were quantified using CT. So this was a study done a few years back. And these were the changes. So if you can see here, the group that increased their skeletal muscle mass had reduced insulin resistance and also reduction in A1C, as you can see, as opposed to those who did decrease their skeletal muscle mass. And on the other hand, those who decreased their visceral adipose tissue also had a reduction in HOMA-IR and also a reduction in the A1C. So you can very clearly see that over a period of 1 year, in these patients who are older adults with type 2 diabetes, resistance training, even at that point of time, could reduce their insulin resistance and reduce their A1C with better glycemic control. So the conclusions of this study were that improvements in metabolic health in older adults with type 2 diabetes were mediated through improvements in body composition, and they had to do high intensity under supervision resistance training. So what it clearly means is that it is never too late to start. And resistance training is an important part of the exercise regimen in order that metabolic control, glycemic control, weight, and sarcopenia are all dealt with this particular kind of exercise. So it's very, very important. Now you will also realize that a lot of people don't have a whole lot of time to do so many things, and yet they wish to burn fat. So this is the newest kid on the block. It has been there. And as I showed you in my very first slide, I talked to you about circuit training, which was right at the bottom of the pyramid. So it was high intensity, but takes the least amount of time and gives you a benefit in terms of fat burning, which is important because then in relation to that, the muscle mass is more and you're dealing with sarcopenia as well. So this is high intensity interval training that is talked about nowadays. So basically, what is this? This is commonly called HIIT, high intensity interval training. Simply meant it is repeated bouts of high intensity effort followed by varied recovery times. So the simple mantra of HIIT is you train harder, that means high intensity, but train briefer, that means you do it for less amount of time. So as I said, one size does not fit all, even in terms of exercise. You have different people with different occupations and different time constraints. And therefore, you can definitely use this in the appropriate patient. And this works on the basis that the epoch, I'm going to show you what the epoch is. It seems to be higher for HIIT. So basically, the post-exercise period is called epoch, which stands for exercise excess post-exercise oxygen consumption, and it is generally about a 2-hour period after an exercise bout, not during. People keep on counting the calories that they've lost when they are on the treadmill. that's not the real picture. I lost 200 calories and I lost this. So it's not that. What is important is that the period after an exercise bout, where the body is restoring itself to pre-exercise level, at that time it is using more energy. So that is very important. That is excess post-exercise oxygen consumption. And what has been found is that HIIT workouts tend to burn more calories than traditional workouts, especially after the workout. And it could be 6 to 15% more calories that are burnt when you do an HIIT bout. So that is the importance of doing this. You get more for less. This is a study which again talks about the effects of HIIT on muscle size and quality in overweight and obese adults. And this study concluded that it may be an effective exercise modality to influence muscle size in overweight and obese individuals. Of course, future studies are required. And this is another study in patients with metabolic syndrome, and they've looked at HIIT and the cardiac autonomic control in individuals with metabolic syndrome, because this has not been studied in the past. Every other modality, parameter has been studied, but probably not cardiac autonomic function. So they aimed to find out whether HIIT had any impact on that. And what did they find? They found that though there was no significant between group differences, but the greatest magnitude of effect for improving cardiac autonomic function was in individuals with the metabolic syndrome. And that's what we want. So it's something to consider. So there are various parameters that are being affected. As I said, it burns more calories in the post-exercise period. And this is another study to show you about the cardiac autonomic function. And it can be done in various ways. In fact, look at all these different kinds of exercise. Any one of them, you can apply HIIT to that. So it's not a particular type of exercise. You could be doing any exercise and you could convert it into HIIT by having intense bouts followed by periods of recovery. So it can be done in very many different ways. So your resistance exercise can turn into an HIIT, your aerobic can turn into an HIIT, and you could be burning more fat by doing this particular thing. And this is just to tell you that these are so many different ways in which you can adopt HIIT. There is no fixed rule for that, and you can gradually work up and go up. So, but you have to be careful, because people who have been very sedentary for a very long time may have increased coronary. If they suddenly start to do it, you could have a problem. Family history, cigarette smoking, hypertension, diabetes, all of these, you have to be a little careful. And medical clearance from a physician is better before you embark on HIIT. And the other important thing to understand is that it should be done very slowly. That means your HIIT periods should be short in the beginning. Your recovery time should be more, and then you can gradually start to build up. So it is very customized, and it should be under a good trainer who understands your body. This is going to be my concluding slide, but my most important slide, where I'm telling you that the ADA 2021 guidelines, though it's meant for diabetes, it holds true for everybody, not just people who have diabetes. So what it says is that most adults with diabetes should engage in 150 minutes or more of moderate to vigorous intensity activity weekly, spread over at least 3 days per week, and shorter durations. You can imagine how much HIIT has caught on and how the evidence is for that, because here it talks about HIIT that may be sufficient for younger and more physically fit individuals, and that may be all that is required. And the most important is the one in the middle panel, which says that adults with diabetes, and for that matter, anybody and also people with metabolic syndrome, should engage in 2 to 3 sessions per week of resistance exercise on non-consecutive days. So this is the most important thing. The takeaway from my talk today is that walking is good, but it is not sufficient. What else should you be doing? If you had time only for one other thing, then it should be resistance exercise. And of course, in older adults especially, flexibility training and balance training are recommended 2 to 3 times per week. And yoga and Tai Chi combine both flexibility training and balance training. And they're very important so that it increases the muscular strength, prevents falls, prevents frailty, and prevents dependence. So that is the important thing. And not to forget, you could that entire day physical activity, that is non-exercise physical activity that we talk about, is extremely important, which I'm showing you here in my last panel. And the reason for this is that if you just exercise one bout in the morning, you finish your HIIT and your resistance training and your walk, and then whole day you are just going to be sitting down, then that is not going to be useful. In fact, it's not going to give you much benefit. So if you want the benefits of all that you did in that morning bout, then you must be active in a small way in your daily activities as well. That is incidental exercise, or rather non-exercise physical activity, to gain additional health benefits. So let me conclude by saying here that aerobic exercise is for all. It increases stamina, it increases cardiorespiratory fitness, but that is not all. Unfortunately or fortunately, we are not hunter-gatherers. So all our body muscles are not exercised in the way that hunter-gatherers did in the past. So we have to do different kinds of exercise to achieve that level of fitness and that level of health. And that is why a combination of all these exercise is a must for overall total general health and metabolic health as well. So thank you all for your kind attention.
Thank you, Dr. Neeta. It was an excellent talk. I think very less talked or less what we see in our practice. You've really given a good overall view of the different exercises and how much to do and how much is the limitations in addition to the regular walking what we do. Dr. Seshadri, do we have time for the questions?
Yes, we have
Yes,
time.
sir, 5 minutes.
Okay. So I think Dr. Shankar wanted to ask some question.
So you're muted, Dr. Shankar, you're muted.
Yeah, can you hear me?
Yes.
Yeah, there is excellent presentation about this sarcopenia. So in elderly patients, especially more than 50 or 44th decade or 5th decade with a gross sarcopenia, are you going to do muscle biopsy to rule out any congenital myopathies or chronic degenerating diseases, or straight away you depend only on the diabetes and then treating the patient?
I think from the diabetes perspective, sir, obviously, as we said, increasing age.
There are so many things. Many times it all associated with the diseases.
Correct. So I think, as I've shown in most of the associated trials, that the division of diabetes and basically diabetes per se increases the risk of sarcopenia. So I think we should probably start with that. And obviously, if basically there is a little bit of a difference in terms of neurological examination, like if you have some motor neuron disease kind of things, fasciculations, some certain bulbar palsy kind of aspects, that's when you look at other aspects. But I think simple things first. I would think that diabetes and sarcopenia are related to each other, so we should start with that.
Thank you, Dr.
Question to Dr. Neeta.
Yes.
So is there any absolute contraindications for this resistant exercises in our diabetic patients, particularly if they have some complications like nephropathy?
So they have bad, retinopathy, and if they have, uncontrolled hypertension, then these are the people, or if they have a very strong family history of coronary artery disease and they have not been checked out, then these are people, I would say they're relative contraindications. They need to be looked into, they need to be treated for this, and then they should be taken up, and in a small way. So resistance exercises can be done even in a small way, even that will have benefit. So one need not, there are gradations in that, and a good trainer will be able to build it up slowly, even in such kind of patients.
Thank you.
Dr. Neeta, for children, if they do heavy exercises, say for example, normally we suggest 45 minutes per day or 150 minutes per week, like that we suggest for adult. For a type 1 dependent on insulin, if they do heavy exercise, their blood level usually varies. Normally,
Yeah.
they will go for an hyperglycemia. What
Yeah.
could be the cause for it?
Well, they need to, first of all, do a lot of SMBG to find out what their sugars are being like when they're undertaking this kind of exercise, and it should be under supervision. And they can get hypoglycemia during such events. There can be a correctional hyperglycemia because of that as well. So there can be a lot of fluctuations leading to severe hyperglycemia also. It's
Yes.
not just hypo we are worried about, it's also a compensatory hyperglycemia. So it's a wise thing for them to, before embarking on this kind of exercise, to do pre and post and during. They need to know their body first and then embark on this kind of exercise.
Thank you, Dr. Nita.
If there are no other questions, I would thank the chairpersons, Dr. Shankar and Dr. Dinesh V. Kamath, for their time and their inputs. Then we had Anand Kumar Annamalai. Thank you very much for this talk on sarcopenia. And Chitra telling us it's always better to ask patients if they're okay, and it's also okay not to be okay. That's the new statement. Please agree, France, that it's okay not to be okay, and people should open up to it. And Nita, you hit hard. So thank you very much. Thank you very much for all of you for this opening session. It was lovely having all of you. Thank you very much. Now we move on to the next.
Thank you, Sanjay, for having with you. Thank you very much.
Thank you.
Thank you,
So,
Sanjay.
we move on to the next talk, and we have we have Dr. Shanmugam Gavel, who's a senior physician, diabetologist, chairman for Tirchi Diabetes Specialty Center at Tirchi. Is very active in diabetes forum deliberations, and I would hand over the session to Dr. Shanmugam Gavel to have two eminent speakers with us, Dr. V. Mohan and Dr. Krishna G. Sheshadri, for their talk. Over to you, sir.
Thank you, Dr. Sanjay Reddy, for your nice introduction. Respected guest speakers, learned viewers and listeners of this program, I feel extremely happy, honored, and most privileged to have been invited to be a faculty for this wonderful scientific session. I thank Dr. S.R. Arvind and his organizing team members, as well as Biocon, the industry-supported symposium, Biocon, for their kind invitation. So we have two topics today. First one is early insulination with basal insulin in new onset type 2 diabetes. What is the level of evidence? So I'm sure type 2 diabetes is a multi-causal, heterogeneous, progressive cardiometabolic condition, and it is characterized by a relentless progression of beta cell failure. Insulin remains the only glucose-lowering therapy that is efficacious through this continuum. A very important thing is the timing of introduction, the choice of insulin therapy remains contentious. Very important. Nevertheless, the early initiation of basal insulin has been shown to improve glycemic control and affects the long-term outcomes in patients with the type 2 diabetes. So we have Professor Dr. Mohan with us. Mohan is a chairman from Dr. Mohan's Diabetes Specialty Center and President, Metros Diabetes Research Foundation, Chennai. He has in his credit several publications, received several awards, including the prestigious BCRI Award, and he was conferred with Padma Award by Government of India in the year 2012. So with this few introduction, let me invite Professor Dr. Mohan sir to make his presentation. Yes, sir. Over to you, sir.
Thank you, Dr. Shanmugam. I'll just get my slides first. I hope it is seen.
Yes, sir.
Yeah. Thank you, Dr. Shanmugam, for this kind invitation. I always rate this meeting as one of the best in the country, and it's not surprising that this year also it's building on where it left off last year, and every year the standard of the meeting gets higher and higher. And therefore, I would like to congratulate and thank Prasanna, Arvind, Sanjay, Krishna, Rohit, Bhavna, and all the organizers of this very, very important meeting. You get the best of the speakers, both from the ADA as well as from India. So congratulations on yet another edition. I work with several companies, and although this is I put Biocon right on top there because this is a symposium sponsored by Biocon, but I don't have a single slide from them, and I'm not going to use a single slide of theirs. So there's really no conflict of interest. This is a very general talk. So how early is early when starting insulin? And so we know that from the time of diagnosis, you have secondary failure to oral drugs and then stage of complications. Now, when we tell our patients to take insulin anywhere along here, including when they reach secondary failure to oral drugs, they all say no. And the typical example I had was an elderly lady who came last week to me. Her blood sugar, she'd taken, she was about 15 years duration. She had neuropathy, painful neuropathy. She had retinopathy. She had microalbuminuria. Her A1C was 14.8 and her postprandial blood sugar was close to 500. She was on 6 oral drugs. And when I told her that I have to start insulin, you should have seen the reaction on her face, she and her daughter, insulin, she said. So almost I thought she's going to die, and I said, did I say a bad word or, something? Did I say, no, you said insulin. I said, yeah, I said insulin. I mean insulin. You're on 6 drugs and it's 14.8. And what do you think, 500 milligrams? Is it a surprise? Didn't you think about it on the way here that doctor might suggest insulin? No, but insulin is wrong. Insulin shouldn't be taken. Insulin will kill you. And all kinds of things. I said, all those are wrong. Just know what you said. And that's what I'm going to give you. And if you're not interested, you can leave right now. The door is open. And you can leave right now, find someone else. A lot of quacks around who will tell you that diabetes can be reversed. Please go find them and they will reverse it for you, but not me. I'm going to give you insulin. And so even when they come to stage of complications, you have no other choice and it's too late. Even here, patients don't accept. But can we start it here when we can control, when they have their 6 drugs, can we start it here? Even there, people will say, no, give me a 7th one, give me an 8th one. But they don't want insulin. So when you talk about giving insulin here at the time of diagnosis, right now a case is going on. In fact, today, my manager was in court. And guess why? Because this guy, one of my clinics he went to, and he had blood sugars of 500, and he had onset, he has lost a lot of weight. And my consultant asked him, can I give you insulin for a month? And that's what this whole talk is about. And he said, I'm going to sue you because you're doing this for the company. And so I'm going to sue you. And he's actually sued me. And now we are in the court. And now I'm actually fighting it out. And here I'm giving the talk on this day when this case is going on. Just now my manager called me. Of course, he's a madman. He's a total nut. That's a different issue. But even here, when you think about it, people get, very, very upset. But if you think about it rationally, early diabetes in inverted commas is not really that early. Because by the time you come to the stage of IGT or IFG, already 50% of beta cell function is lost. And when you diagnose diabetes, when the 2-hour value crosses 200, you've got about 80% of beta cell function, which is gone. Of course, some of it is recoverable, as I'll show you. But at that particular point of time, if you measure the C-peptide, and if you're doing it serially, you'll find that 80% of your insulin is down. So it's not a bad idea to consider insulin at that time, although it may not be needed in everyone, unless there are some indications for it. And not everybody who is diagnosed at that point needs insulin. Certainly not. If your A1C is 7.2, nobody's going to give you insulin at that particular point. But is there a role at all? And is this concept correct that we're actually making up for lost time and lost beta cells when we start treating diabetes early? Now, this is an early study, Diabetes Care, where they looked at some of the trials, and then some of them had used pumps, some of them had used short-term insulin. And here are 3 of them. The ICOVA study, the Lee study, and the Ryan study. Fairly small numbers in 2 of them, 13 and 16, but one of them had about 100 patients. But all 3 of them showed that the response early was very good, 92%, 88%, 90%. So 90% response by giving temporary insulin for a month or so at the time of diagnosis. But look at the sustained response. After 26 months, 24 months, 12 months, 69%, 42%. So already it has dropped. Even after giving insulin for a month, there's still a drop. That's because it's a relentless condition. In many people, it's relentless. So when these quacks come around and say, in everybody you can reverse diabetes, every single diabetes. So I've asked people, so if somebody's got 40 years duration, all complications, you can reverse them. Oh, yeah, we can reverse it. Totally. I said, okay, thank you. All the best. I can't. I'll refer them to you. You reverse them because you are the reversal guy. I'm only a treatment guy. but this reversal thing has become so common among the quacks today that we are considered almost like criminals. If you suggest insulin or tablets for diabetic patients, we are all, bought by pharma. And that is why we are giving, not because there's nothing called diabetes, as one of our senior physicians in our own, profession keeps saying. But this is a randomized clinical trial. This is by Weng et al. This is the best study, small study, Chinese study, but beautifully done. Lancet 2018. And what they did here, decent numbers, 133 people on CSII pump, 118 patients on multiple daily insulin, and 101 on oral drugs. So this is a question that people ask me, why don't we just give them oral drugs? And of course, in this particular context, it was glycoside plus metformin. So now they'll say, if you give SGLT2, will you get the same effect? Well, we'll have to try and see whether you'll get the same effect. But this particular one used two common drugs at that time in 2008 versus insulin. And the point is here, focus your attention here. If you look at the delta increase in the acute insulin response, it was best if the pump was used, a little better if multiple daily insulin was used, and oral drugs also seem to have the same effect. So at first glance, it looks as if, well, oral drugs can also do it. But as I said, you have to wait for a year or two. And a year later, if you look at the drop in the insulin, not much in the first two groups which required insulin, but more than a 50% drop when only the oral drugs were used. So in this RCT, there was clear evidence that using insulin first, just for 3 to 4 weeks, actually just a couple of weeks or 4 weeks at the maximum, helped to improve the beta cell function. What about Indian data? Well, this is one paper which we published some years ago with Dr. Jatinder Kumar Mokhta from Simla, about 122 patients, dramatic improvement in postprandial blood sugars shown here, as well as in the fasting blood sugars shown here, sustained for a 3-year period. So you can see this dramatic drop, which is kind of maintained almost like a flat line in those who took insulin. Now, the drop in A1C again, 11.4, dropping to around 6, and then being maintained. Remember this graph, because I'm going to show you a hypothetical graph a little later on. So it's possible for people to maintain this kind of good diabetes control. Here is another study, a larger one, 426 patients, where we collected more data, importantly on C-peptide, because Mokhta couldn't do C-peptide. So we did C-peptide. There's a lot of data in this paper, but I'm just showing you the C-peptide. So this shows you the fasting C-peptide and the stimulated C-peptide. At the baseline, before we started the treatment, all of them were newly diagnosed. Insulin was given for 4 to 6 weeks. And you can see that the fasting insulin improves after 2 to 3 months. This is after a year, further improvement, as in contrast to other groups where only oral drugs are used, where it drops, it's actually improved. And at the end of 2 years, it's still maintained, still much better than the baseline. And the stimulated C-peptide, even better, 1.60, 2.5, 2.78, a slight drop after 2 years. Now remember, this contains people who have delayed for 5, 10, even 12 years or so. If you take individual cases, you can get a much, much, much better beta cell response, almost coming back to normal in many cases, especially if you have HbA1cs around 9, 10, and so on. You can get a complete reversal of the beta cell function. Now, this is a study from Dallas. And what they did in this study was they gave insulin for 3 months. And after giving insulin for 3 months, they followed up the patients for 3.5 years. And they found that this recovery of the beta cell function could be preserved for 3.5 years if insulin was given for 3 months. Normally, I give insulin only for about a month. But if you give it for 3 months, they found that 3.5 years, it could be preserved. I wanted to show you this particular graph because this is a patient of mine, a spiritual leader who's very disciplined, who gave me this graph about a week ago. And you can see the last one is August 21. He came to me first in July 2011, and initially with a HbA1c of 14.5. So he too almost reacted like this lady, which I told you last week. He said, insulin, doctor, of all things in the beginning. I said, believe me, trust me. You're a spiritual person, and I'm not going to give you insulin if it is unnecessary. Believe me, it will have a long-term effect for you. He said, I'll go by what you say. I trust you. That's why I've come. So I treated him with insulin. The A1C dropped to 7, first to 9.2 and then to 7. every time it went up, a little indiscretion. And I also told him to keep coming every 3 to 4 months. Regularity is important. And you can see 7, 8, 6, 7, 5.8, 7, 6, 7, 6, 7, 6, 7, 5.8. That is last year. 7.8 recently, and again down to 6.7. So he gave this to me and he said, here's my gift to you. 10 years you have sent. You remember, doctor, you told me at that time that if you give me insulin, I'll be able to maintain it. I think you have done it and I have done it. Therefore, I wanted to give this to you. I said, I'm going to show this without mentioning your name. And he said, by all means, if you can use this to tell people that early insulin is good, please do it. So that's why I'm showing you that. This is a 10-year follow-up. And this is not the only case. I've got a large series now, 5 to 10-year follow-up. After giving insulin only for 1 month, you're still getting the results after several years. Now, there have been systematic reviews and meta-analysis, because the title of this says, where is the evidence? So here is an evidence looking at systematic review that short-term insulin therapy can improve the underlying pathophysiology of type 2 diabetes and thus improve the natural history of diabetes. They're not talking about improving the A1C. They're talking about reduction in the insulin resistance, improvement in insulin sensitivity, and improving the beta cell function. And this is what is shown in this paper in Lancet Diabetes. Now, this is the paradigm which I wanted to show you. I said, remember that graph I told you. The usual way in which we treat is to start in a laissez-faire attitude. So what we do is we start with diet alone, then let us try for 1 year, then we will introduce an oral drug, and then we'll introduce a second one and a third one and a fourth one and a fifth one and a sixth one and an eighth one. We'll go on and on and on. And at every time, the A1C will be above 8%. Okay, so you can see that this patient has never reached 7 ever in their life. And that's the time when they come to us, somewhere there. And then the discussion is, should you take insulin at that particular point? My point is, you should have done that many, many years ago. Diabetes is a progressive disease, and therefore you have to hit hard and hit early. So if you push it down, so I call this as paradigm A, and this is paradigm B. So if you look at paradigm B, we're hitting hard and getting the A1C down to 6, as I showed you in the previous slide. And then every time it goes up, it's come down. It looks as if that gentleman's curve is actually extrapolated on top of this, and you can see how beautifully it's maintained. And therefore, the average is kept below 7. So guess what? If I was to give you a prize, there's no prize needed for this. Who is going to develop complications? The guy treated with paradigm A or paradigm B, there's no big no prize to be won by saying that the guy with the paradigm A is going to develop the complication. That's why some of us do develop these complications. Early insulin initiation reduces chance of developing multiple complications. There's a lot of evidence for that. Diabetes-related endpoints, myocardial infarction, microvascular complication, of course, no doubt at all. The guidelines are unanimous in recommending basal insulin, because when you're going to start insulin at the time of diagnosis, it's not necessary to give them a pump and to give them 3 times insulin, 4 times. I think it's an overkill. In my experience, 1 basal insulin is enough. And you can give it in the morning or give it in the evening. All they need is some insulin. And every guideline says that. Of course, the Indian guideline has also included premixed insulin, because sometimes the postprandial sugars are very high. So nothing wrong in using premixed. And some of them did use premix. They've dropped it now. But uniformly, basal insulin is accepted by every single guideline in the world at the time of initiation, if the A1C is very high. Does this approach work in all people with type 2 diabetes? It doesn't. If somebody tells you that all works, remember the paper's 100% sensitivity, 100% specificity. I mean, there's nothing like that. There's no 100% specificity, 100% sensitivity in medicine. If somebody tells you that, ask them to go and hang themselves, because it's not going to happen. So this doesn't work in everyone. For example, this particular study showed that in the RISE consortium study showed that in young people, in youth, where even if you treat them with intensive insulin therapy, you're not going to get as good results as you get in older people, because it's very difficult to treat young onset type 2 diabetes. It's a very, very difficult to treat animal. And therefore, ladies and gentlemen, if I were to conclude and give you the implications for therapy, early and aggressive treatment type 2 diabetes can reduce glycemic burden, promote good metabolic memory, and favorably alter the natural history of the disease. Consider a short course of basal insulin in all newly diagnosed patients, A1C above 10%. Even 1 to 2 months of insulin therapy can work wonders. 10 years is a long time, as improvement in both beta cell function and insulin resistance can occur. And this new paradigm may help, at least in part, in reversing the the natural history of type 2 diabetes. And I'll stop there and thank you all for your patient hearing.
Thank you, Professor Dr. Mohan, for your insightful and lucid presentation on this particular topic. What I gathered information, early is not really early. Insulin can be started at different points along the natural history of type 2 diabetes. And you have mentioned many evidence demonstrating the multifaceted benefits, including overcoming the early glucotoxic effects of hyperglycemia, thereby facilitating improvement with reference to beta cell function. In fact, it improves patient chances of reaching the goals, reducing the risk of complications, and you have nicely mentioned guidelines are unanimous in recommending basal insulin as the initial insulin of choice. Thank you, sir. Now, let me, sir, please stay with us. We'll take up the question at the end of the...
I'll do that. I'll wait for the questions.
Thank you so much. Thanks a lot. Thank you so much, sir. Bye. Next is regarding the second topic, choosing the right biosimilar insulin, science to consider. And before that, let me give a brief introduction about this particular topic. That is, biosimilars, they are unique molecules. They are not generic versions of the innovator biopharmaceuticals. And very important thing is, there are potential efficacy and safety implications. We know the cost of the reference molecule, namely Glargine, that is associated with substantial cost. Biosimilar or follow-on biological insulins or insulins with a demonstrated similarity in terms of purity, potency, safety to an approved insulin analog. So for this particular lecture, may I call upon Professor Dr. Krishna G. Seshadri, consultant endocrinologist, Chennai Diabetes and Endocrine Clinic, Chennai, and he is a clinical and research lead, Apollo Sugar, Chennai, to take through this presentation. Over to Professor Dr. Krishna G. Seshadri, sir.
Thank you, Professor Shanmugavelu. Dr. Mohan, thank you for that wonderful introductory talk to this entire session. I hope all of you can hear me and my slides are visible.
Yes, Chris.
And please note that I have several conflicts of interest. I have speaking honoraria from most insulin producing companies. I also hold some advisory positions and some research grants that may or may not be considered as influential. Please be aware of it. Let's start with biosimilar insulin. Before that, I think one of the interesting things that I noted is a DIY insulin. Being a DIY world, do-it-yourself world, for those that there are DIY insulin kits available for you to make insulin at home, just like they used to brew alcohol back in the 40s in the US and for forever in India. So you could brew insulin at home. All it takes is some bacteria, some tissue to grow it, some fermenters, and of course you could end up dead, like many of the patients that received insulin prior to the 1922 experiments that we saw. So clearly there is a need for insulin, and the reason I even talk about this is that after 100 years after insulin, we still have an access problem. Not everyone is getting the insulin that they need, and not everyone is getting insulin that is safe, effective, and cheap. So that is one of the reasons why biosimilar insulins come. And first thing to understand is that these are biological products. That is, they are made by other bacteria or fungi. It is a DNA process. These are inserted into these organisms and they make it huge fermenters. It is then purified and it is carefully monitored to ensure quality. These are not generics because the process we don't have a control over how it is made. It's made a certain way, and then there are cleavage products. The important thing is that there is an understanding that there is a reference product. For example, for the insulins that we talk about, it's glargine. And what is basically happening is that there is already an established product. The person who is, or the innovator, is not sharing you the guideline or the handbook, but has set for you that this is how it looks, this is how it functions. When you inject it, this is the glucose response, this is the HbA1c response. If you're able to make it, fine. There are regulatory authorities that will allow you to take it. So what you will have to look at is the physicochemical characterization, which is its purity, its molecular structure, its bioactivity. And as I'll show you, that no molecule is the same. It's like having snowflakes. While we look at clinical trials in the innovator products and its safety and its efficacy, the pharmacokinetic and the pharmacodynamic studies become very, very important in biosimilars. Similarly, an immunogenicity assessment, whether it produces antibodies, and if these antibodies will either reduce the efficacy of the molecule or can be toxic in some other way, is important. As I said, when someone comes and tells you about too many clinical studies in biosimilars, you need to ask them, you know what, this is nice, but I'd like to see your pharmacokinetics. And after that, it should meet standards. And the EMA and the FDA and the DCGI and many others look at these. And you know, in the past, when we've talked about biosimilars, I've spent a lot of time looking at each of these regulatory agencies. Today, I think, you know, these are pretty commonplace. And lastly, it's functional characteristics and clinical performance. And I told you that the clinical performance is important, but you really don't need large RCTs, and you should, and they won't exist also. So what are they not, right? If someone comes and tells you that I have a better insulin than glargine, then that's not a biosimilar. That's a new insulin. Is it can it be a copy? Like, can someone do a Chinese way, go ahead and you know, spy on the originator, look at their test products, and then come and redo it? Sure, you can. And they are biomimics or copies, they're not biosimilars. They're not generic drugs, because generic drugs are basically small molecules. Aspirin is a generic drug. Rosuvastatin can be a generic drug. Your sulfonylurea can be a generic drug, because these are chemical products. These are not biological products. Right. So today we are doing a Biocon symposia. So this just tells you the number of global trials that were done. Many countries actually asked for their own PK/PD data during the biosimilars, and so I remember actually being in Colombia for one of these, and it was very interesting to see that just across the United States, but they would not accept that particular information. And of course, Japan always has its own trials. The EMA has a single standard. Of course, the United States is a late adopter in biosimilars, but they will insist on their own ones. These are some clinical trials, basically to establish non-inferiority. Remember, superiority means that this is not a biosimilar, right? That looked at type 1 diabetes. And remember, these are all small studies. You really don't need a large phase 3 RCTs that we can dissect out in terms of confidence interval. You just want to make sure it's working like the original. Otherwise, you're going to have another multi-billion-dollar product that is not going to reduce the cost for patients. So this is looking at the Biocon's glargine insulin versus the reference insulin, and this was looking at A1C change at 24 weeks. And you'll notice bang on, as if somebody has copied and pasted on it. And no statistical significant difference. And the dose, which is also important. Remember the big thing about dosing and whether it changes, no difference between the biosimilar insulin that we're talking about today and the reference insulin glargine, which was the Sanofi product. Right? And of course, no difference in terms of any time or nocturnal hypoglycemia at 55 weeks. So we know it's safe, it's comparable, it's efficacious. And this is the INSIGHT study that said that there was not much difference in terms of clinical activity, toxicity, and maintenance of glycemic control over a period of time. This is the same thing in type 2 diabetes, which is the INSIGHT-2, a 4-week screening and randomization of 1:1, a 4-week follow-up. A1C seemed like, somebody has cut and pasted on top of it, right? No, non-inferiority margin was 0.4%. The dose over time was really not different. Hypo and hypoglycemia are just the same. And again, even in type 2 diabetic patients, not much to choose between the two insulin. And what happens if you switch? And this is type 1 patients. And what happened where these are patients who were switched to glargine plus Lispro versus reference glargine to Lispro and back. And this is 36 weeks and nothing much to change. So this is the red line is a non-switching, the blue line is a switching sequence. That showed you basically these are much the same. There was no difference in terms of standard deviations in both of these. Importantly, the immunogenic data, which is very, very important for biosimilars, there was no difference in the immunogenicity of the two molecules. Remember, biologics are important and proteins. I'm preparing for a talk on Sunday and remembered that, that for a long time, we couldn't establish that insulin was a protein. And then, it took almost 14 years from the discovery of insulin for us to establish it as a protein. And of course, in the 50s, Sanger sequenced it. And it's very important to understand that, that the way the insulin folds, and I remember I actually helped launch the biosimilar, but I talked about how it folds. It folds 1, 2, and 3. And if it doesn't fold right, you don't get it right. So how does it work for us? Why should we consider a biosimilar insulin? One, there should be an indication, of course. There should be proof of safety. There should be bioequivalence with the innovator molecule. That's very important. It should be efficacious to the same level, and it should have immunogenicity. And of course, the most important reason why, there are two reasons why we need biosimilars. One, we need to not have monopolies. The moment you have monopolies, you have restricted access. Also not have the competition that brings prices down, right? And that's very, very important. The second thing is, at this point of time, there are many people in the world who do not have access to insulin. The availability of, people may call it copycat molecules, but they're not, of cheaper, available biosimilars, which you allow the innovator to have time to grow their own thing, to make their money, to make their return on investment. After that, you want to allow everyone else to have a share of the market because that's the only thing that drives the price down. So what should be worried about? Is there safety that is established? Are there comparative therapeutic studies? Is there a low quality substandard procedure? It must be very clear that there have been instances in the past where these have all created problem, whether this is erythropoietin, whether it is even the old Marvel insulin. We must be very clear to see if the pharmacodynamic studies and the pharmacokinetic studies are a clear match. So is there a need for concern? You should be very careful. One is biosimilar insulins are highly similar to the reference biological, but remember, as I said, it's like having two snowflakes. They're not exactly the same. You must be very clear that there should be no meaningful clinical difference. That is, it's variable. There is equivalent quality and safety. And of course, they pass the regulatory approvals in various countries that they are sold in. As I talked about in the beginning, when you talk about an originator, what he starts off is a bunch of in vitro studies where they show that there is some proof that at least it works on a cell. And then, of course, you have non-clinical in vivo studies or animal studies and of course, animal dose ranging studies also to show that there's proof of concept. Then in humans, you have the clinical pharmacology or the PK/PD studies, which show that there is equivalence. And of course, there is clinical studies which take up the really big amount of the budget of the development. It's the opposite with the biosimilar development. You need to sort of build this bottom up to create the exact product. The amino acid sequence, the kind of lysis, the protein binding, the protein folding, and then of course its receptor binding, its characteristics, all of these. A lot of this is done by the mathematical modeling helps a lot of this, but not necessarily. This is really hard work. And then you have to, and can you see, you really need a lot more in vivo studies to build up your file. And of course, the PK/PD, you need to be exactly the same. And of course, you gain a little because you don't do as many clinical studies, but you still have to do efficacy and immunogenicity. You really don't have to prove, that it has the same CVOT or the others. So that's where you save the money, but it's still expensive and it can be. So where do we stand with biosimilar insulins now? The approvals are increasing and it's a big, huge market. The EU has product-specific insulins and the guidelines for insulin. This is there for others also. And every country has its own regulations. Both the EMA, the European Council, the FDA. And an important thing is that in many countries today, you can do interchangeability. That means that in a third-party payer, if the doctor has written a innovator insulin, the health system can actually substitute it. That was a big discussion, but people are comfortable now that the healthcare system can actually substitute an insulin based on the safety and efficacy of the product. What about the impact? Biosimilars really should be helping us move towards affordable therapy. And maybe in patients who can't afford it, this can, as Dr. Mohan very beautifully talked about, insulinization should be early and timely. And whether people are taking drugs just because they're cheaper is an important question. And of course, it does help reduce the cost. There are a lot of benefits of biosimilars to the healthcare system. I think today, hematology and oncology and nephrology would not survive and patients would be in great trouble without the biosimilars. We should see that this happens in diabetes also at some point of time, because while insulin is fairly inexpensive in India, it's still not inexpensive to reach everyone. And of course, not to even talk about the rest of the world where this is important. So you need cost-effective medications. You need patients to be able to afford insulin. Slowly, these costs will become important in driving the competition. And of course, we need innovators. We need them to make their return on investment. After all, remember in the last 10 years of the CVOTs, there weren't many people, many companies that actually invested in drugs because of the CVOTs. So when you have regulation that impairs innovation, that's not good. But at the same time, you want a balance where patients at some point of time are brought into the system and benefit and reap the benefits of medications. I will stop here. I thank you, and we will take. I'm happy to take questions and join the panel with Dr. Mohan. I think we have about 20 minutes left in this particular panel discussion. Thank you very much again.
Thank you, Professor Dr. Krishnaji Seshadri, for your excellent, elegant, and highly informative talk on biosimilar insulins. So, with reference to biosimilar insulin, it has similar physicochemical characteristics. That is very important. Similar pharmacodynamic and pharmacokinetic parameters with reference to reference molecule. Non-inferior glycemic efficacy and similar safety as well as immunogenicity profile with reference to the reference molecule. And nice to hear the INSPIRE 3 study switching between biosimilar insulin glargine and reference insulin glargine in patients with the type 2 diabetes did not appear to impact glycemic control. That means the glycemic parameters with reference to efficacy same, safety profile same, and there is no statistically significant difference with reference to immunogenicity according to your version. It is safe, effective, affordable, as well as accessible by the patient. And 2 years, I would like to add, it is available and it is acceptable by the patients. So 4 years, affordable, availability, and acceptability and accessibility by the patient. It satisfies the need. And of course, you have clearly mentioned with reference to cost effectiveness, 40% reduction in the cost of the therapy compared to the reference molecule. Yes, sir. Thank you very much. Now, Dr. Sanjay Reddy, can you...
we have opened for questions. We have time.
Yes, sir. Chat box. You can open the chat box. Let us see.
I'll just see if there anything in the chat box.
Yes, sir.
I don't see anything. So
there are 2 questions in the chat box already, but we can also do a panel because I think we are slotted for a panel also. So.
There are 5. Yeah, now I can see. Sorry. Yeah.
Yes. First question, Dr. Rajesh Joshi to Dr. Krishnaji Reddy. Krishnaji Cheshadri. Which biosimilar glargine is approved in India and efficacious as original product?
Okay, I think we should be aware of the history that the biosimilars actually made it into the market a little earlier than the regulations actually came in, and almost all the biosimilars made it into the market before the regulations for new biosimilars. So, but almost all of them have at least some data on file that shows that they are equivalent in terms of their PK/PD. One should review those carefully. Use the PK, especially the PK/PD data. If you have, if the only question that I would ask a biosimilar insulin to come and show me is, one, if there is an approval process to show that they are approved. The second is to actually look at their PK/PD data. Are they bang on? Are they compared to? Has it been done in more than one facility? Has it been compared with the biosimilar glargine, which was a Sanofi product? And of course, how do they look when the curves are superimposed? Are they absolutely the same? So that's so. But remember that most of the this thing, except I think the Lilly one, which came in after the DCGI regulations, all of these were in the market when the regulations came in. So you can't go retrospectively and impose regulations on an existing product. Maybe Dr. Mohan can add on to this.
Yeah, absolutely. I think in terms of quality, you really cannot choose between them. And the fact that they're being made in India is something which we can be very happy about. And the fact that other countries have accepted, these are also, for example, a country like Japan, very, very stringent in accepting. They have accepted biosimilars made in India. So unless the quality is good, I don't think it can make it into a Japanese market or to European market for that matter. And cost definitely plays a big role. At the 100th year of insulin, I remember that article, I think it was in New England Journal, where it said 100 years of insulin for some, it had said. So, so it's only for some that's insulin even today after 100 years. And I keep writing in many places I've written that Banting must be turning in his grave because he didn't take a single dollar. He was supposed to take in $1, by the way. He didn't get it. He said, I didn't even get that $1. And so he gave it away free. And then that insulin, which he gave away free, and he said, it doesn't belong to me and it belongs to the world. Today, the world is not able to get it. So 100 years later, would Banting have been happy? I don't think he was never a happy man. And today, definitely he would never have been happy. He would have been unhappy for the simplest of reasons. And for the reason that it's not available in the rest of the world, I don't think Banting would have been happy. So we have to make Banting happy now. We have to give insulin to everybody.
It's very interesting because the number of misfits who got together to make that product.
Absolutely. And the fight and the thing, the movies made about it, it's a different, books are written, movies are made. At one point when Collip didn't tell him, I don't know if they know this, Collip came and quite innocently said, I have solved it now. Now I know the formula. And Banting said, tell me. He said, I'm not going to tell you. Why should I tell you? He said, you have to tell me. I discovered the insulin. And he said, I'm not going to tell you. Banting bashed him up and put him on the floor and hit him and he got injured and called back. So right up to that. Do you know that there's not a single photograph of the four of them? because Banting refused
No.
to stand with McLeod for any picture. So that's why he didn't go to receive the award. He said, "I'm allowed to stand with him. The press guys will ask me to stand." So he said, "I'm not going to stand." So he didn't go. He gave the award, the lecture the next year. So, I mean, that's a different story.
It was very interesting
the point
because,
is you should give insulin to everybody. That's the point.
in fact, they wrote it up for the university, and ultimately, what was interesting was that there were two drug company owners who were actually sitting in the presentation, and in the US, Eli Lilly got it, and of course, we know what happened in Europe. Again, very interesting story. But the thing is, access is a big issue,
Even
especially
today,
in the
after
rest of the
100
world.
years. When human insulin came, the what was promised to us was that it'll become so cheap, it'll become like water, because that didn't happen. And when I started my practice, insulin was 12 rupees. Of course, 12 rupees that time was much more expensive. But then the cheaper insulins went away. I wish we had those animal insulins, just to keep a few people alive. If at 12 rupees we still had insulin, it would have been fantastic. So
the thing is, Dr. Krishnaji Seshadri said, we need to have access to all data with reference to biosimilar insulin, I think. We need to have data.
Absolutely.
Accessibility also. Yes, sir. So next question to Professor Dr. Mohan sir. That is Dr. Nagaraj Patil. My compliments for the wonderful presentation. Should start of basal insulin be considered only if presenting A1C is greater than 10%? Can we think of initiating early insulin irrespective of A1C, as it anyways helps in preserving beta cell active?
So, Dr. Nagaraj Patil is a good question, and we really don't have the answer. For that, you really have to have trials starting at 8%, 9%, 10%, 11%. I just put a number 10% because at least then you can double figures HbA1c, at least then you think about starting. Because today you can argue that, after the verified trial and so on, that if you use a combination therapy, 2-3 drugs, maybe you can get those at 7%, 8%, up to 8.5 or 9%. You may get under control if you use triple therapy at least. But above 10%, there will be definite leukotoxicity and there'll definitely be lipotoxicity. And there will be some symptoms. Most likely, the patient would have lost. They might have developed vulvaginitis or balanitis or loss of weight. There could be mild ketosis. They could even have retinopathy or something. So at least in those cases, let us start off with it. There's nothing wrong. We can't do a trial now at 8%, 9%, 10%, 12%, then take another 20 years to get the trial. What are we doing? We're just getting one vial of insulin, giving it till that vial is over. What does it really hurt when you do that? And we're getting such dramatic results if the C-peptide is improving. But to answer Dr. Patil's question, if you start with, for example, look at the Origin trial, where 6.5, 7, 7.5, they gave insulin to see what happens. Nothing happened, because when the diabetes is so mild, what is the point in giving insulin then? There's no point. Probably diet, exercise, little metformin or something should be sufficient at that point. So the case I'm making for is at 14, 15, don't think say whether 3 drugs will work or 2. Because each drug, if it brings it down by 1%, from 14 you're not going to bring it down to 6, 8% A1C reduction. You're not going to get. Whereas with insulin you can get any A1C reduction. So that is the point I'm trying to make, that at least there you start. And of course, the beta cell function will be lower the higher the A1C. So if your A1C is only 7.5 or 8, you're not going to have very low C-peptide. So the real low C-peptide come, that 80% reduction, which I showed you in that graph, is for people who have really uncontrolled diabetes. And that's where you see the dramatic reversal. So the higher it is, the more the dramatic improvement that you will find.
Yes, sir. My question, you have clearly shown the C-peptide response after initiating the patient on basal insulin. Right. My question is with reference to improvement in HOMA-IR after basal insulin. Yes, sir.
It's been shown by others. I haven't measured because I don't routinely do HOMA-IR. C-peptide is a routine assay at our center. But if you look at the other studies which I've done, where I showed the improvement in the natural history of diabetes, they've shown both. They've shown reduction in the insulin resistance as well as improvement in the insulin secretion. So both defects have been shown because you're correcting glucotoxicity and lipotoxicity. When you do that, the insulin is going to work better. So what does insulin working better mean? That the insulin sensitivity has improved, the resistance has come down. So I don't think it's a big surprise if the HOMA-IR actually improves after good control of diabetes. Yes, Krishna?
No, sometimes I think, we should start using words like cardiologists that, start using words like stunned beta cell.
Yeah, exactly.
That with these high glucoses, your beta cell is actually stunned.
Correct.
And we can reverse it by lowering the glucose. I think a lot of us get caught in this pathophysiologic treatment paradigm. Yes. But no pathophysiologic treatment is going to work unless your beta cells have a modicum of their function restored.
That's right. And so saving beta cells, I think, is one of our, at least insulin resistance by doing exercise and so on, you can improve. But exercise is not going to improve your beta cell function. What we are very disappointed in our studies, one of my doctors finished his PhD recently and he worked on bariatric surgery. So what I definitely thought was that when you lose 40 kilos in weight and your A1C comes down from 14 to 5.6 or something, that your beta cell function is going to improve. No, it didn't. Of course, I selected very late cases. We don't do bariatric surgery when 7.8 HbA1c. I don't go and do bariatric. That's a referral bias. So we take only the worst cases, don't respond to anything. Last resort, we do that. We found tremendous improvement in HOMA-IR. HOMA-IR drops like that, becomes normal. C-peptide is the same. It didn't, because remember, for that weight, the C-peptide was good or bad. And when you lost weight, you don't need that much beta cell function. So the C-peptide really didn't improve at all. So it is not that just by reducing weight, your C-peptide will improve. Beta cells are beta cells, and really you have to improve them. And you have to improve them, you have to correct the glucotoxicity. You have to use drugs to stimulate the beta cells in an ideal manner. We don't have all the answers for that. So just weight reduction is not enough.
In fact, in at least in some in vitro studies, we know that the de-differentiated beta cells actually improve with insulin. We have no proof in humans.
Yeah. In cell experiments, they have shown animals. They go in hiding and they become alpha cells, and they're actually waiting, the alpha or delta cells, and they're waiting there. The moment you give the rescue therapy and give the insulin, correct the metabolic insult, the beta cell comes back, and that's why the C-peptide is improving. If the cells were dead, you cannot improve it by giving insulin and so on. Once they're dead, they're dead. So this just shows that there's no apoptosis. The cells are just waiting to be rescued. It's like somebody on an island, they're just waiting for a ship to come and then rescue them, So when you're giving the insulin, like, giving them a rope and then pulling them out and before they die, So that's the kind of thing, and we should keep this in mind. And irrespective of, I can tell you, not all patients accept. But let me tell you, there's a lot of patients who also accept. Because once you see why did this man come and present me this 10-year thing? It's like a report card he has come and given it to me, earlier this month. You keep this, he said. I said, I'm going to show it to people. He said, please. That's why I showed you this. He's so proud. 10 years, he's kept his A1C at 7%. And he says, I didn't believe you when you first told me, but I think it has something to do with that. It's never crossed 7.5 throughout for 10 years. And so he was very, very convinced. And he was saying, tell more people about this talk. Let people get. And there are people, where they've brought it down so well that he'll bring a sister or he'll bring someone else. There's magic treatment right for me. My sister also needs it, So give it. So see how we're changing society now, So people think we are converting people on insulin to support pharma. Come on. We don't have to support pharma. We are trying to treat our patients and to help our patients, So that is what we are trying to do. And it's a short-term insulin, giving it for 1 month. What is it? What pharma does it help by giving it for 1 month? So that's a kind of allegation saying that, they're all giving insulin just to support and nothing like that. If you believe in helping the patient, you must use it. Don't worry about what people say.
Yes, sir. You normally tell early initiation of insulin, it provides beta cell rest.
Exactly.
Yes.
Exactly. Yeah. You're telling them, it's like, two crude example. One is a horse is tired. Keep on beating it more and more and more. I'll give more sulfonylurea. I'll give 3 drugs. I'll bang it. So it's that's the same principle. You give the horse rest 2 days, the horse will run again. That's the first example. Second is the water in the well is going down. What will you put? A bigger bore pump you'll put to take out all the water, or you'll allow the water to come up for some time. Use buy some water for some time and let the water in the well come up again. That's exactly what you're doing. You're giving insulin and allowing your pancreas to get it back. And we are removing all the glucotoxicity around the pancreas. So the cells are now again differentiating and coming back. And actually see it happening.
Yes, Sanjay Reddy, do you find
Sir,
any other questions?
No, I was listening to the stunning conversation between Dr. Krishna. I'm trying to make something as a comment. Stunning conversation between Dr. Krishna and Dr. Mohan, sir. It was interesting to note all these facts, and then we are making for the world. I think we should be proud that we have something which has been made for the world now. Insulins for the world.
Absolutely.
I think that's the proudest thing we can take back. I was talking to somebody, actually Sam Tiago Jacon always comes back. There's no insulin plant in Africa. Such a huge continent, except for South Africa. I don't think they have anywhere else. They have to get it all the way across from Europe or elsewhere. Now that is the disparity with insulin, and just wanted to add, and the cost of insulin. So thank you, Dr. Shanmugavel, for moderating the session, Dr. Mohan sir for this lovely discussion, and Dr. Krishna
Sanjay. Thank you, Shanmugavel.
for giving us the.
Kumar there. Hi.
Yeah. This is waiting for us. He's the next speaker. So
I know.
thank you very much. We have a couple of minutes, but thank you very much. We're right on time. Thank you.
Good evening, sir. Good evening, sir.
Good evening, Vijay Kumar.
Good evening, sir. Shanmugavel, sir. Krishna ji.
Good evening, sir.
Good evening, Vijay.
So we have 5 minutes more, so we'll put in some icebreakers. Can RX guys, if you have this, or Ravi? So we have 5 minutes. Arvind is in the other hall. He has to join, but I'll be there till he joins, so I can move there and he comes in for discussion. Yeah, you're in all here, right?
Shall we start?
No problem.
No, not for this. We can start, but we're early, right? 4, 5. 2 minutes more? There is a pharma symposium sponsored by a grant from USV, and then we have 2 speakers, Dr. Vijay Kumar, a dear friend, and Dr. Abhay Kumar Shamu, another friend from Cuttack. And to moderate the session, we have Dr. S.R. Arvind. He's actually speaking in the next hall. He will join us. We have Dr. Krishna also here, Krishna Sheshadri, to take it forward before Dr. Arvind joins us into the. But we still have 5 minutes. We'll give time for people who want to log in at that time, a couple of minutes before we start.
You're not serving coffee?
Can you wait for 10 minutes? I'm in a meeting. Recording.
Coffee, but anyway.
One of the things that people probably miss in this is Sanjay's famous hospitality.
Oh, come on.
That is such a thing in any conference.
So we'll just play some icebreakers with it. Just in. Deepa, can you play some runs 3D conference every year at Chennai. Over to you, Dr. Vijay Kumar, for your talk on modern sulfonylureas, trusted companion of past, present, and future.
Yeah, thank you, Sanjay. Can I share the slides?
Yes.
Yes. Thank you. Good evening to everybody. Thanks, Sanjay, Bhavna, Dr. Arvind, for giving me this opportunity. Thanks to USP for sponsoring this program. And I also felt that this is a very, very practical topic. We may have so many drugs that are available in our in the market for us to use, but sulfonylureas has got its own place, and a permanent place rather. It's a permanent place. Thank you. Good evening to everybody. Thanks, Sanjay, Bhavna, Dr. Arvind, for giving me this opportunity. Thanks to USP for sponsoring this program. And I also felt that this is a very, very... Okay, can I speak? Can I? Hello?
I think so. I think you were coming on quite right, Vijay. Can you hear me clearly now?
There was echoing of what I spoke.
I know, that's exactly what I also felt. I think that's gone. Yeah, I think you can continue speaking, Vijay.
Thank you, Arvind. Thank you. Thank you. Good evening to you. Okay, and you know that sulfonylureas have got a permanent place in treatment even in future. That's what I personally feel. And that is the crux of how we get convinced about sulfonylureas. It's a trust. It's going to be a trusted companion for our armamentarium for management of diabetes from the past, the present, and even in the future. That's what we see. You know that we got several first generation, second generation, third generation. First generation include the talbutamide, clopidogrel. And in the second generation, we had glibenclamide and glipizide and glycoside. And in the third generation, we always call that glimepiride is supposed to be the third generation sulfonylureas. See, one of the beauties of sulfonylureas is a time-tested molecule. This is a time-tested molecule. You could see that it has got more than 60 years of experience in sulfonylureas in general. And then it is the first pharmacological class of oral anti-diabetic drugs used in treatment of diabetes. Since till then, we were using only insulin. And even this is even before metformin was invented, actually. So sulfonylureas have been there for more than 60 years. And it's interestingly to note that it is accidentally they found that sulfonylureas. During the World War II, when they were using sulfa antibiotics, this World War wounded soldiers, when treated with sulfa antibiotics, they suddenly found that a lot of people dying because of hypoglycemia. And then it's how the sulfonylureas have come into place. Now, if you look into this brief history of sulfonylureas, you can see that in 1937, they found that hypoglycemic effect of the sulfur compounds. And at 1942, they found this when trying to treat typhoid with sulfonamides, they found hypoglycemia. And only in 1946, almost about 10 years later, it has been found that Auguste, from French physician, they have proved that sulfonylurea compound stimulated release of insulin from pancreatic beta cells. From that, it took about 10 years for the first sulfonylurea in the form of talbutamide was introduced into the market in Germany, and then later on chlorpromide and other drugs have come. And it took another 30 years before a safer molecule such as glibenclamide in those days, glipizide, have been introduced. In 1995, the safest sulfonylurea in the name of glimepiride has been introduced into the market. In between, 1 or 2 years earlier, the glycoside also was coming in between. Now, sulfonylureas have been time tested. The reason why I'm telling time tested for so many years, especially the modern sulfonylureas such as glimepiride and glycoside. They are safer and better bet for us to use. And if you can see that in the 1970s, UGTP has created ripples amongst people, stating that tolbutamide has increased the risk of myocardial infarction. But then, in spite of that, it was available till about 25 years. It was available in the market even later on. And then in 1980s, we got second generation supplements in the form of glibenclamide and glipizide are available. And these had a better safety compared to the earlier ones like tolbutamide and chlorpropamide, profile as new sulfonylureas. And then in UKPDS, when sulfonylureas had been used in the form of glyburate, that is glibenclamide, CV safety has been restored, but they found no protection. Then came the advanced trial about 10 years ago, that is about 2008, and it has clearly stated that in RCT, where in this particular trial only glycoside has been used, no other sulfonylurea has been used, and then you can see that CV safety has been demonstrated. And in 1917, recently, in the TOSCA-IT is a study. You can see that it compared glibenclamide, glimepiride, glycoside with pioglitazone. All the three molecules were compared with the pioglitazone. And then this latest one is Carolina trial, where glimepiride has been pitched against linagliptin. We'll look into the details of each study probably. Yeah, UKPDS, chlorpropamide, glibenclamide has been used. The comparator is only diet control, and then follow-up is about 11 years. And then the number of patients, you can see that number of subjects in the study you can see here. Advanced trial, modified release of glycoside, and then there was a standard arm treatment is a comparator, and 5 years of follow-up. TOSCA-IT, where the glycoside, glimepiride, and glibenclamide are used, compared with pioglitazone. This is what a active comparator has been there for 4.8 years, and Carolina is again a bold step that they've taken, where the glimepiride has been compared with linagliptin. Right. This is a Carmelina trial the previous year when linagliptin is found to be cardio-safe compared to as safe as placebo, and so the safest DPP-4 inhibitor is being found, and they compared glimepiride with linagliptin. That's how it is. It's followed for 6.3 years. Now, if you look into that, there's some differences in this. UKPDS has got no data on CV mortality, no MACE. Similarly, advanced trial has got a CV mortality data, but no MACE is available. But whereas TOSCA-IT and Carolina have got everything. For example, especially glimepiride, Carolina trial has got all-cause mortality, CV mortality, myocardial infarction, stroke, and MACE. All those things are the data that is available is for everything. But other molecules are equally good, like advanced, but there is no MACE data is not available. Now we look into the findings that each of these main studies. If you can see, advanced trial has shown that intensification of glucose control with glycoside modified release was not associated with increase in incidence of CV events. That means cardio-safe. UKPDS again, no difference in rates of myocardial infarction. Rare deaths, sulfonylurea versus insulin therapy for intensive treatment, and then similar incidence of CV events compared to pioglitazone. The pioglitazone is also considered cardio-safe, and pioglitazone versus sulfonylurea as add-on to metformin. When they added to metformin, no difference. And Carolina trial has shown the safest in the linagliptin compared to glimepiride. There is no difference. It's as safe as linagliptin. Now, so it is put into the statement in Indian Journal of Endocrinology and Metabolism. You can see that modern sulfonylureas such as glimepiride and glycoside should be initiated early in the course of type 2 DM to achieve maximum glycemic benefits and obtain the benefits of metabolic memory. So you can see here. And then no doubt why later on you can see that RSSD has come out with a statement in 2020, but IDF has been there from the beginning, stating that metformin, the drug that choice has been given is sulfonylurea and even alpha glucosidase inhibitors. But only recently the ADA and others come out and said that it's also a good choice to add to metformin. Sulfonylurea is also a good choice. That's what they said. And the reason why, you can see that in ADA, if you can see that metformin efficacy high, potential benefit in CV, and cost is low. And modern sulfonylureas, high efficacy, neutral towards heart. That is because safety. Now you got the data I have already shown. Low cost. And similarly, if you can see that IDF also came out of the same thing. Metformin and sulfonylurea. Sulfonylurea is supposed to be neutral in major CV events or heart failure. And then metformin has got a benefit with the CV events, and then neutral with metformin. Now, the question is that when you have a cardio beneficial metformin and cardio-neutral glimepiride, if you combine these two things, you're going to get benefit because efficacy is very, very high. You can see that both metformin and sulfonylurea efficacy is very, very high. So if you combine these two drugs, the advantage is going to be great. Because why is it so efficacious is because a complementary mode of action of sulfonylurea and metformin. So glimepiride acts on the beta cell dysfunction, metformin acts on insulin resistance, and invariably the hepatic glucose output also comes down, insulin secretion is increased, and then a combination of these two drugs with complementary mechanism of action helps in addressing multiple etiologies of hyperglycemia. No doubt why, as I said that, if you look into the several combinations, you can see that sulfonylurea, metformin, rosiglitazone, pioglitazone, metformin, rosiglitazone, metformin, DPP4 and metformin, pioglitazone and DPP4, you can see that the most effective, after insulin, the most effective in reducing the HbA1c comes from sulfonylurea plus metformin. It's about 1.7. It is expected to be like that. So it's compared to any other because you got one anti-hyperglycemic drug and a hypoglycemic drug. A good combination and a complementary mode of action. Now, if you look into that, suppose somebody is on metformin, whether you want going to up-titrate metformin or add a glimepiride, what are the advantages that we can? In this particular study, we can see by adding FDC, that is fixed drug combination of glimepiride and metformin, we can see that from baseline HbA1c 7.9 to 6.6, whereas when you do the metformin up-titration, it comes from 7.8 to only 7. So a better glycemic control when you add glimepiride with metformin rather than up-titrating the metformin. The same thing could be seen with fasting blood sugar and postprandial blood sugar as well. So instead of going for up-titration, and you always remember that one statement called as half maximal dose. If you have a half maximal dose concept, because you get 90% of the benefit of half the maximal dose of each molecule. In order to get some 10% benefit, you need to double the dose, and you end up within several side effects profile. Now, so because of all the benefits and efficacy and safety, you can use it as a monotherapy. You can use it as a dual therapy along with metformin, triple therapy with either DPP4 or SGLT. You can add to that, and even you can add alpha glucosidase inhibitors to that. And then you can add also to the basal insulin this combination of sulfonylurea and metformin. So you can add any drug to this combination, and this is what we do in our practice. In general, most of our majority of the patients are on sulfonylurea metformin combination, and then we try to add some other drug like DPP4 or this thing. Now, one of the other benefits that we have. So whenever you're trying to use any molecule, if you're not subjecting the beta cells to be overstrained, then it's a very good molecule. So if you see here, the glimepiride, glibenclamide, glycoside, and glipizide, if you can see that, the amount of blood glucose comes down. You can see here. You can see here. This one, the blood glucose. And the amount of insulin secreted to get this effect, you can see that glimepiride scores over this minimal insulin secretion compared to even glycoside. So glibenclamide is very high, glipizide is also high. So you can see that this is because glimepiride, apart from having a beta trophic effect, beta cell trophic effect, it also has got improved insulin sensitization. So that's the reason you got insulin sparing effect. This is a pleiotropic benefit that we can think about. Now, if you look into that, off late we are looking into the clusters. Now we have several clusters even in our country. Indian type 2 diabetes like SIDD, IROD, CARDO, and MARDO, and overall. If you can see that These two are majority of the clusters that we see in our country. The clusters are formed from several aspects into taken, including HbA1c, the amount of insulin, C-peptide levels that they have, and then HOMA beta, and so many things will take into consideration, and they make into clusters. The advantage of going for clusters is we can, to a certain extent, we can find out what is the treatment that is going to be more effective in this particular cluster. So clustering is going to be this thing probably in future. Now, in the last 10 years, when they divided into the clusters, and they found that most effective combination therapy in various clusters has been, the best is found to be with sulfonylurea metformin. Here you can see that. You can see that 13.7, 26, 26.9, and 21.8, and 32.6, you can see that. And overall it is 25.2. And whereas if you see the metformin is the next with 11.3, and then metformin DPP-4 inhibitor is 6.4. So it looks like that this combination seems to be in various clusters as well. It seems to be effective. So it's a very good trend. Now, if you look into the treatment preferences, this again based upon the effectiveness and usefulness amongst the practitioners. If you look into that, consulting physicians, if you can see that the metformin and glimepiride, if you can see that as a second-line treatment, and then you can see that there is no change over the years. It continues to be there, metformin, glimepiride, metformin in the first-line treatment, second-line treatment, as well as third-line treatment. Now, recently, dapagliflozin has found to be increasingly being used along with metformin as a first-line treatment. And then similarly, it is being continued in even the second-line and third-line treatment. And again, one more thing which has been found to be used more by the physicians is the voglibose combination. You can see that voglibose combination around glimepiride metformin has been used. What is surprising to that, we don't know why, but the usage of metformin and teneligliptin in the last 2 years has been coming down in usage, the combination. But the vildagliptin metformin combination is increasing usage. Now, that is one study. This is one more study which is in metro and non-metros. You could see that as a second-line treatment from 2019 to 2020, the usage of glimepiride metformin has increased from 9.3 to 11.59%. Okay, whereas teneligliptin has come down from 12 to 5, and vildagliptin is improving over the time. You can see that from here in the second-line therapy, that is a first-line therapy. If you look into that second-line therapy, if you can see 2019 to 2020, you can see that there is a big jump from 4% to 6.5% voglibose and metformin use. And metformin vildagliptin, you can see that from 2% to 18%, close to 17.5%. And there is no death for glimepiride metformin combination. So you may get many combinations, but it is evergreen. Sulfonylurea metformin are evergreen. So that means this is because this is the prescription patterns. That is because we have the prescription patterns, their effectiveness. Only then you can do that. So it looks like modern sulfonylurea in diabetes care because of extra pancreatic benefits, cardiovascular effects, other pleiotropic benefits like antioxidant effect and other things, and anti-inflammatory effects also have been found. And that is the reason you can see that they are more useful. So now, as far as efficacy is concerned, there's no doubt about that. Even compared to DPP-4 metformin, sulfonylurea and glimepiride with metformin is more useful. And then let us look into the safety aspects. Whenever you're trying to use sulfonylurea metformin, both in the form of hypoglycemia, CV safety, and weight gain. So these are the things which have always been, people used to, discuss that, is the end of the road for sulfonylurea. Sir, is it true? Let us look into that. Compared to glibenclamide or glycoside and glipizide, glimepiride seems to be having the least hypoglycemic episodes next to metformin, which is 4.1%, whereas other molecules have got higher hypoglycemic effects, like 14.2 in glycoside and 11% with glipizide, and then 36% with glibenclamide. Now, in the combination therapy, Compared to glibenclamide metformin, glimepiride metformin, the rates of hypoglycemia are almost close to 30 to 70. Again, this is because of the molecule glimepiride has got a effect on the beta cell in the sense that physiologically active. Association and dissociation. As the blood glucoses are high, it associates the sulfonylurea receptor on the beta cell more time and then secrete insulin. As the blood glucose comes down, and it dissociates itself from the beta cell receptor. And that is the reason you could see that the least hypoglycemic episodes. Now, as far as the cardiovascular safety is concerned, we know that it is cardiovascular safe in all the other studies like Carmelina and Carolina trial we have seen, and several other trials also we have been seen that sulfonylureas, modern sulfonylureas are very safe. But here is an experimental done in 45 patients. What they have done is that they have done the occlusion of the carotid artery and with a balloon occlusion, and then they injected the either placebo, glimepiride or glibenclamide, and then balloon dilatation is being done. Even during the balloon occlusion, the so-called cardioprotective ischemic precondition is being continued whenever you use glimepiride, which is not available with glibenclamide or with placebo. So that's a very, very important thing. Now, one of the reasons why people put on weight with sulfonylurea is because when the glucotoxicity comes down and the high blood glucose levels they are there, because of hyperglycemia, they could have lost weight and they will regain that same weight as before. But one good thing is that you can see that Zodiac trial, where glimepiride has been used, from baseline to 5 years, even in such obese people like 90 kilo percent people, you can see that there is no difference in weight with metformin glyphosate group after 5 years. And similarly, even in advanced trial, there was only 1 kilo increase over 6 years or so. So it is a myth that sulfonylureas are going to increase the weight heavily. No, it's not that. So if you look into that, the misinformation that we have, if you think that there is increased risk of hypoglycemia, it's not true. We have seen the information that we got. There is definitely no increased CV risk, and it is more efficacious than what you are thinking, and weight gain is only a myth again. So let us not worry about all this misinformation that has been if you are getting into that, you can avoid all this information, which is not a very good one. And you can see that unless it is efficacious and safe, the prescription patterns would not be so strong with this particular combination, as I've already explained. So friends, let me conclude to say that sulfonylureas have remained the mainstay of pharmacotherapy in the management of type 2 diabetes, not only efficacious, safe, and it's got a pleiotropic benefits, and also cost effectiveness. Cost is very low. Every patient can afford to use a modern sulfonylurea today. Glimepiride is an oral antidiabetic, can be chosen as an initial monotherapy or a combination with oral antibiotics in treating type 2 diabetic patients. And modern sulfonylureas such as glimepiride are backed by a large body of evidence, experience, and most importantly, outcome data. It supports their role in managing patient diabetes. And then please do not hesitate to start this combination therapy. In fact, even though we have been using the combination as a first-line therapy, the earlier algorithms used to say that no, we have to start in whatever the HbA1c may be. You start with the metformin and then uptitrate it and then add a second molecule. That means you are doing that. But we have been using this. So if the blood sugars are higher, the HbA1c higher, there is no harm in going for a combination therapy in the beginning itself. It is said that if your HbA1c is more than 8.5, go for a combination therapy in the beginning itself, and later on you can readjust the combination therapy. So friends, thank you for your patience.
Thank you, Vijay. Thank you so very much for busting all the myths surrounding sulfonylureas. So you made it very clear that safety, efficacy wise, it's fantastic. And then cardiovascular safety has now been proved, especially after Carolina. So I will come to the questions at the end of this session because we have one more brilliant talk, and Abhay Kumar Sahu is already ready. And So he'll be talking about dapagliflozin, the universal treatment option for type 2 diabetes. He's an endocrinologist, professor of endocrinology at IMS and SUM Hospital, Bhubaneswar, and he's been speaking in most of the meetings in India, and his face is already familiar to most of us. So he'll be talking about dapagliflozin and more with dapagliflozin. Abhay, the stage is all yours.
Thank you, sir. So, so my slide is visible, sir?
Yes, it's visible. You're heard well. Yes.
Yeah. Thank you, sir. So I'm going to present after this brilliant talk about sulfonylurea. I'm going to present is dapagliflozin is the universal treatment option for all type 2 diabetic patients. So over last 1 to 2 years, we have actually listened a lot about dapagliflozin. We have now almost in each and every meetings, we have a lot of discussions about SGLT2 inhibitors. So once DAPA is off level, that actually has changed the scenario of treatment of particularly diabetic patients in Indian populations. So if you see the type 2 diabetes as a cause, as a future risk factor for particularly any sort of complications, then a cardio-renal-metabolic catastrophe happens, because once type 2 diabetic patients, we have up to initial phase, there are certain components of metabolic syndrome will be there in each and every patient. And we know that by the time a diabetic is detected, almost each and every person have some sort of complications, because the process of diabetes starts almost a decade earlier. And in future, they develop either a cardiovascular disease or a CKD or nephropathy, or they end up with a cardio-renal complication. And the most important part is the majority people die having death due to cardiovascular disease. And once you discuss cardiovascular disease, probably there is one component is atherosclerotic cardiovascular disease, where myocardial infarction is one of the important factors. Whereas in the other part, there is form failure, and that is leads to actually heart failure in a large chunk of population among the type 2 diabetic patients. So there is an urgent need to save more lives with SGLT2 inhibitors, because actually I'm not going to discuss what SGLT2 primary preliminary data is, because everybody in this August gathering know that over last few years we have actually listened a lot about SGLT2 inhibitors. So now what in crux, people see the SGLT2 is causes glycosuria, and what is the effect on the heart? They causes reduction in the blood pressure, they reduces preload, they increases the non-steroid fatty acid utilization, and also increases the ketone body utilization, and that gives some substantial benefit from the heart failure point of view. In the lipid, they causes increased lipolysis, also increase non-steroid fatty acid uptake, and ultimately leads to decrease in the fat mass. In beta cells, they causes increase in glucagon with decrease in insulin and reduces glucotoxicity, and probably gives some sort of beta cell rest due to this reduction in the glucotoxicity. And in particularly liver, there occurs increased hepatic glucose output, increased non-steroid fatty acid utilization with increased ketogenesis. That probably is one of the pathophysiological mechanism by which this SGLT2 causes reduction in the hepatic steatosis. And another important part is in kidney, where it causes reduction in the tubular, it causes restoration of the tubuloglomerular feedback mechanism, reduction in the oxidative stress and inflammation, and also, of course, it causes natriuresis in the kidney. And all those factors actually plays a critical role giving protection to the kidney point of view. So we know that these are the over last several studies which has been actually published with dapagliflozin, and if you'll see what are the crux that from these studies, that how this cardiorenal risk is reduced from the HbA1c target, that this is the HbA1c target with the standard treatment with the intensification algorithm. And if you are discussing about each and every cardiorenal risk independently, then patient who's having ASCVD risk factors, then probably all guidelines is telling go for SGLT2 inhibitors or GLP-1 receptor agonist, having proven benefits from the cardiovascular point of view. If someone is having heart failure, then of course SGLT2 has the main role, and SGLT2 plays a critical role, and it should be started early. And if someone is having CKD up to GFR 30, then either add on or switch to SGLT2 inhibitors with proven benefits. And if SGLT2 is not tolerated or contraindicated, in that case, you can go for GLP-1 receptor agonist with proven benefits. These are all guidelines has been actually over last several years we have got. Now let us discuss how dapagliflozin is helping us in achieving these distinct considerations for ASCVD, heart failure, and CKD. And these are from the DECLARE TIMI studies, where actually they have taken all preclinical diseases and also clinical diseases between from the ranging up to 0 to 20 years. What they found, they can cause reduction in the heart failure hospitalization significantly. And then after that, the DAPA heart failure study, where actually they have taken both diabetic and non-diabetic population, and what they found that there occurs significant improvement with those who are having even if established heart failure, and this end stage heart failure is significantly retarded once you are using this dapagliflozin. Again, among the type 2 diabetic patients, if you want to CKD point of view, this DECLARE TIMI has clearly shown up to 20 years there is slow declining in the kidney function. Again, DAPA, a dedicated renal trial, DAPA CKD trial, has clearly shown there occurs slowing progression of the established cardiovascular CKD among the dapagliflozin group. So that also shows that there is significant improvement in the CKD patients once you are using dapagliflozin. Then what is the important part is among the Indian diabetic populations, those who are diabetic, they have almost 5 times much more risk of heart failure, and 3 out of 4 type 2 diabetic patients have subclinical cardiovascular disease. These are the 2 important parts. So how we are going to address both parts? So this is the DECLARE TIMI trial, which has clearly shown that those who are having established cardiovascular risk factors or established cardiovascular disease, dapagliflozin causes a 17% reduction in the composite endpoint in comparison to the placebo group. So that shows that even if those who are having established CV risk factors or established cardiovascular disease, they are getting benefit from the dapagliflozin. Again, the DAPA heart failure study, where actually almost 45% is having type 2 diabetes and almost 55% people have non-diabetic. Irrespective of the diabetic status, what they found, there occurs reduction in the cardiovascular death and heart failure events. So among the diabetic, the reduction of the cardiovascular death is almost 25%, and reduction in the worsening of heart failure by 23%. And again, if you take non-diabetic, they are getting much more benefit than the diabetic. Among the non-diabetic, the reduction in the CV death is 27%, and reduction of worsening is also reduced by almost 38 to 40%. So both the diabetic and non-diabetic groups are getting the benefit from the heart failure point of view. Again, second part is that 2 out of the 5 type 2 diabetic patients develop CKD. That means the incidence of CKD in the diabetic patients is almost as high as 40 to 45%. So how we are getting benefits from the dapagliflozin? The DECLARE TIMI has clearly shown DAPA delays the progression of the kidney disease and also reduces the event incidence. How? It reduces the new onset macroalbuminuria by 46%. It reduces the new onset any sort of albuminuria. If you combine toto, that both micro and macroalbuminuria, then it is reduced by 21%. And albuminuria category deterioration, that means those who are having micro, if they are deteriorating to macro, and those who are having macro, if they are deteriorating to end-stage kidney disease, that is reduced by almost 27%. So DECLARE TIMI has clearly shown there is significant benefit from the renal point of view. Again, the DAPA CKD, the dedicated trial, has shown the dapagliflozin improves renal function and mortality among the patients of CKD with and without diabetes. So the primary outcome is sustained more than 50% eGFR decline and end-stage kidney disease with renal and cardiovascular involvement in comparison to placebo, almost a 39% risk reduction with dapagliflozin. Again, if you want to see the secondary outcome and only they want to see the all-cause mortality, that is reduced by 31% in the dapagliflozin group. So again, DAPA CKD, where both diabetic and non-diabetic were taken, that clearly shown there is a significant reduction in all-cause mortality, and also the cardiac mortality, renal mortality, and decline in GFR, everything is significantly improved. Then next part is 1 out of every 3 type 2 diabetic in India are found to be either obese or overweight. So how this is giving benefit? almost we know that once you are using any sort of SGLT2 inhibitors, there occurs a weight loss of around 3 to 4 kg. And the crux is that this weight loss is not due to loss of lean body mass. It is the loss of fat that gives the advantage to the type 2 diabetic patients. So if you need the total body, almost body fat 50 to 75% is reduced, and body water is and also other proteins is not significantly changed. So subcutaneous fat is reduced by 25 to 45%, and visceral fat is reduced by 25%. So the dapagliflozin reduces total body weight predominantly by reducing fat mass, visceral adipose tissue, and subcutaneous adipose tissue. That is the advantage of use of dapagliflozin over other drugs. Again, what is happening? Is it really a sustainable weight loss, or that is for a short period of time? People see this is a 4-year study, and this is up to 2 years. And again, that the extension of the study has clearly shown that even if up to 4 years, dapagliflozin weight loss is well sustained. This is the DAPA group, where actually loss is almost from the baseline is 3.7 kg, whereas in the comparator glipizide and metformin group, there is a weight gain of around 1.3 kg. That means if you see from the group where actually glipizide and metformin was given, probably the weight loss is as high as up to 5 kg. Whereas absolute weight loss in the dapagliflozin group is in the range of 3 to 4 kg. So that is due to loss of the fat. Then another important, the recent studies has clearly shown up to that these are the 70% of the type 2 diabetic patients has non-alcoholic fatty liver disease. And the recent studies has clearly shown dapagliflozin also giving benefit in that. So this is as a disease modifying effect on the patients of type 2 diabetic patients with NAFLD. And dapagliflozin monotherapy reduces all major hepatocyte injuries, including the biomarkers. Also, it reduces the FGF21 level. And the study compares the DAPA versus SITA and pioglitazone. DAPA group experiences a significant improvement in the liver inflammation. There occurs alteration in the liver fibrosis. There also even if reduction in the body weight, and all those gives significant improvement in the non-alcoholic fatty liver disease. And another important part is 2 to 3 times higher prevalence of anemia in the type 2 diabetic patients in Indian population. We know the anemia is quite prevalent. And again, if we take the female population, they have much more degree of anemia in comparison to the dapagliflozin and in comparison to the male counterpart. So what this shows, dapagliflozin corrected anemia in almost 52% of patients and also reduces the new onset anemia. So this is the proportion of patients with anemia at baseline and how they improves in the dapagliflozin group. Almost 52.3% patients, those who are having baseline anemia, by not even if they have not given anything with dapagliflozin itself, the causes improvement almost in 53% cases, whereas in the placebo group it is only 25% cases. And if you see those who are having no anemia at baseline, how many people develop anemia in future? It is dapagliflozin group, it is 2.3%, whereas in the placebo group it is 7%, which is again the difference is 4.2%. So that shows that DAPA itself has some sort of role in improving anemia among those people who are actually using dapagliflozin. And again, this is one of the important factors, particularly those who are having CKD patients, because we know CKD anemia is one of the important factors in the CKD that gives the benefit to the CKD patients. Another important among the Indian diabetic patients is 3 out of 4 type 2 diabetic patients have hypertension, and that shows if you see the dapagliflozin, both systolic and diastolic blood pressure is reduced and in the range of almost 6/3 or 5/2 in this range. So dapagliflozin lowers blood pressure in patients with poorly controlled hypertension despite of receiving ACE inhibitor ARB. So all those people are already at baseline on ACE or ARB. Once dapagliflozin was added, there is an additional reduction in the systolic blood pressure, and that is actually gives significant benefit to those who are having uncontrolled blood pressure. And another important key part is we can tell that for a single person, a blood pressure reduction of 5/2 or 6/3 might not be significant, but a community, those who are taking lakhs or 10 lakhs people who are on dapagliflozin, in those community, a reduction of blood pressure 6/3 probably is quite significant, and that gives a significant benefit from even if the cardiovascular and renal point of view. And up to 36% patients of type 2 diabetic patients diagnosed in women are irrespective of age is found to be associated with polycystic ovary. And we know again type 2 diabetes and PCO are 2 important factors. And if you see the potential benefits of DAPA in different metabolic and cardiovascular benefits of PCO, then it improves the fast phase insulin response from the beta cell, hence preserves the beta cell function, decreases the blood glucose level along with lowers the blood pressure level. It enables the glucose and sodium reabsorption, which promotes glucose excretion in urine. It improves insulin sensitivity and glucose uptake in the muscle, and decrease gluconeogenesis and enhances lipolysis and reduces the fat in the content of the liver. They reduces the visceral adipose tissue and hence promotes weight loss. So all those factors in type 2 diabetic patients, those who are obese or those who are having associated polycystic ovary, they also get significant improvement from the use of dapagliflozin. So recent studies of SGLT2 in PCO patients shows there is promising improvement in anthropometric parameters and body compositions once you are using dapagliflozin in those group of patients. And 1 in 6 people with diabetes in world is from India. That is another part, that India, after China, probably India is the next country having the highest number of diabetic populations. And how this Indian population, Indian diabetic, will get benefit from particular use of dapagliflozin, that this Indian diabetic is little bit different. How, in spite of lower BMI, our South Asian populations, they have more abdominal fat, and they are called thin fat Indians. They have more insulin resistance and hyperinsulinemia. They have very high level of C-reactive protein, which is considered as acute phase reactant. They have very low level of adiponectin, and they have a characteristic dyslipidemia. They have low HDL, high triglyceride, and high level of small dense LDL particles. Again, there is increased susceptibility to type 2 diabetes and coronary disease. And we know that coronary disease occurs almost a decade earlier in Indian type 2 diabetic patients in comparison to the Western counterpart. So how dapagliflozin is giving benefit to our Indian type 2 diabetic patients? This high abdominal adiposity and visceral fat at any given body mass index, we know that SGLT2 itself causes significant weight loss, along majority loss is due to loss of visceral fat than the subcutaneous fat loss. Higher waist circumference and waist hip ratio, again due to this weight loss, there occurs reduction in the waist circumference, that gives benefit from the insulin resistance point of view. The lower level of adipokines with high plasma leptin increases the concentration of the triglycerides. So dapagliflozin causes reduction in the triglyceride, also reduction in the leptin level. The lower rate of glucose disposal in dapagliflozin causes increase in the glucose disposal. And in the diabetic, that is impaired insulin secretion with increased insulin resistance. This DAPA causes improvement in the beta cell function and also reduction in the insulin resistance. So if you will see how dapagliflozin is giving benefit to Indian type 2 diabetic population, that is quite significantly giving the benefit. So 4 out of 10 type 2 diabetic patients in India use insulin alone or in combination of OHS. That is also important factor, that dapagliflozin is the ideal partner for type 2 diabetic patients on insulin, because it improves glycemic control, it promotes weight loss, improves insulin sensitivity and beta cell sensitivity, lowers blood pressure, and you can reduce the dose of insulin once you are adding dapagliflozin. Reduces the albuminuria and renal, gives protection to kidney. It reduces the risk of hospitalization from the heart failure. It reduces the risk of cardiovascular disease and mortality. Also, you can discontinue 1 or more additional OHS if someone is taking, once you are adding this SGLT2 inhibitor, specifically dapagliflozin. So this is does saving lives really cost more money? So this is particularly dapagliflozin's, this UDAPA is therapeutically equivalent to innovator brand dapagliflozin. This is a study where actually UDAPA is compared with particularly innovator brands, and they found that the bioequivalence of the innovator brand of dapagliflozin is almost similar to UDAPA. And there is no significant change in once you are also switching from the innovator to generic UDAPA. H1C p-value is 0.9. There is no significant fasting reduction. Again, p-value is not significant, and BMI reduction is also p-value is not significant. So that means that this UDAPA is at par with particularly UDAPA is at par with particularly the use of particularly the innovator dapagliflozin with a similar incidence of mycotic infections, that is 6.8 versus 7.4. Again, if you see UTI, it is 4.1 versus 3.9. So as far as dapagliflozin for universal treatment of type 2 diabetic, the question should be, why not? With long-term improvement of glucose control, dapagliflozin helps in prevention of diabetic complications. If you are using in the early stage, probably you can prevent the future cardiovascular renal complications, and its benefits in particular specifically in the cardinal risk, obesity, NFLD, anemia, hypertension, those who are on insulin, and also PCO patients. So this generic DAPA is a universal economical option for all type 2 diabetic patients. Thank you.
Thank you, Abhay. Thank you so very much for making it so very clear. I think Vijay Kumar is also back after a short break. There were 2 brilliant lectures covering DAPA. In fact, many of the physician populations who are not able to see very affordable patients in the past did mention that when the DAPA generics came into the market, they really felt happy that they can actually give DAPA to everybody. And you also very clearly showed us the bioequivalence of the originator with the generics that we have in the market, especially the DAPA. Still, there is a question in the minds of many of our physicians. If my patient has a normal BMI, he is likely to lose weight, which is not liked by him and his family. Can I still use an SGLT2?
Yes, sir. Actually, if you see the dapagliflozin, specifically the studies of innovator dapagliflozin, they have actually used dapagliflozin in different groups, including BMI close to 19 up to BMI 40. So what they found, when the BMI is close to 18 or 19 or normal BMI or less than 23 as Asian population, in those groups, the maximum weight loss is only half kg. Whereas if you are taking a BMI close to 40, there is a weight loss of as high as 6 to 7 kg, 8 kg. So that means it depends on how much fat is there in the body. And also it's not necessary that everybody will lose 3 to 4 kg. And if a person having BMI 19 is losing 4 kg, probably it is not good for that person. So once a BMI close to normal, there is a maximum weight loss of around half kg is there. But when the baseline BMI is close to 40 or morbid obese, there is a weight loss of as high as up to 8 to 9 kg with use of dapagliflozin. So we can use safely in those groups.
Okay. I think that clearly...
The metabolic parameter is actually well preserved, or the metabolic effect of dapagliflozin is well preserved, even if in the low BMI patients.
Yeah, I mean, you also have thin, metabolically unfit patients in India. I think it should certainly help most of them. Now, there's another question that, do I have to be watching the eGFR closely when I'm using an SGLT2, especially DAPA? And what is the ideal eGFR at which I should stop using this drug?
Sir, actually, once when the dapagliflozin came to the market, at that time, the labeling was 60, up to GFR 60. But once the DAPA CKD trial has come, again, the CANA trials has come, now actually up to GFR close to 20-25, we can safely use this dapagliflozin, or even if all SGLT2 can be safely used up to even if GFR 20-25. And even if you are getting below that, you might not get the specifically the glycemic benefit of SGLT2 inhibitors, but of course the metabolic other additional or the extra glycemic parameters, extra glycemic benefits will be still there, even if you are using in that low GFR. In no way it is going to harm the patient. So if the GFR is low, probably the glycemic benefit will be lost, but all the cardiovascular benefit, renal benefit still well preserved in those group of patients. So it can be safely used up to GFR 20-25.
I think that's a very, very clear answer that you have given. Now, let me go back to Vijay Kumar. Vijay Kumar, after your talk, I and Dr. Krishna Seshadri were discussing about what you mentioned about hypoglycemia and sulfonylureas. And he did mention that hypoglycemia is a necessary evil in all diabetics, and you must learn to live with it. He said it's like getting married. You must learn to live with your wife, and there are days when she can be more nagging, and there are days when she is not nagging. It all depends on how well you educate your patients. So I think hypo is the only little hurdle that's in the path of a sulfonylurea today, because it has passed all other hurdles: cardiovascular safety, its efficacy, everything it has passed, cost, everything it has passed. What do you want to say about this little hypo? Because we have to use insulin sometimes. So what do you talk about hypo and sulfonylureas?
No, with insulin and sulfonylureas, is it?
No. I mean, at some time or the other, many of our patients will require insulin. So hypo is a part of diabetes.
A part of diabetes, that's one thing. And then the other issue is that, the modern sulfonylureas are definitely, that evidence shows that the episodes of hypoglycemia are far lower compared to the earlier sulfonylureas. That is number one. Arvind, you have brought out a very nice point. It's hypoglycemia is a part of your life. Now, if you look into that ACCORD trial, the famous infamous, I would always say that famous infamous. I always feel that UKPD has told us how to treat diabetes, and ACCORD trial has shown how not to treat diabetes. In that way, is a taught. Both the things have taught different things actually. If you look into that ACCORD trial, in the sub-analysis of the post-trial analysis, cross-section analysis, it has shown that those people who died because of hypoglycemia, but basically who never experienced hypoglycemia earlier, suddenly they developed an hypoglycemia and got into troubles. That's what they said. But those people who had a small amount of hypoglycemia more often, they have survived better. That's what the analysis shows. They're indicating that, something like a preconditioning, ischemic preconditioning. Hypoglycemia preconditioning is one concept which has been brought in. It does not mean that you create hypoglycemia. I'm not trying to say that. As I say, that part of life is a mild hypoglycemia once in a way. Sometimes may be beneficial. We don't know about that. But it shouldn't be so severe to cause a problem to people. That's the only thing one matters. So,
in fact, you brought out a very good point. If you go to the sub-analysis of the ACCORD trial, severe hypoglycemia was actually more in the group which went for relaxed control than the tight control. That was number one. 2, Carolina sub-analysis, if you go, even though glimepiride shows 3 times more hypoglycemia, hospitalization for heart failure was more in the linagliptin group. It was not in the glimepiride group. Okay. But these things are often not very clearly told when we talk of sulfonylureas and hypoglycemia. So I think hypoglycemia, even in Carolina, only when they started increasing the dosage of sulfonylurea from 1 to 2 to 3 to 4 milligrams, people felt some amount of hypoglycemia. This was the basic statistic. So it is known to cause a little hypoglycemia. And as long as the education is proper, I think we can really get away. Abhay, now you have spoken about DAPA. And Vijay, you have spoken about sulfonylurea. But in a clinical setup, if you have to start one drug after metformin, Abhay, what will you start? Vijay, what will you start?
Sir, actually, people ask me 5, 7 years, 10 years back, after metformin, I used to start sulfonylurea. There is no confusion or ADP4. But of course, nowadays, we have definitely, after sulfonylurea, we are definitely shifting to SGLT2 inhibitors. There is no confusion. Actually, this is my clinical practice. I am doing it nowadays like this.
Vijay?
Yeah, see, it depends on the scenario of the patient at that particular time. If the blood sugars are very high, HbA1c is very, very high, I would rather like to go with a combination of sulfonylurea metformin and then bring it down the blood glucose levels enough and then retitrate the glimepiride content in the, if at all I'm going to FDC, I'll be titrating the glimepiride dose of it. And if the same patient has got also some cardiovascular issues, maybe the HbA1c is very, I don't mind going for a triple drug combination with the glimepiride, metformin, and as well as DAPA. I don't mind doing that actually.
Then where do you...
But here, sir, I want to add something that if someone is having an initial baseline HbA1c is high, even if a DAPA metformin combination is quite sufficient to reduce up to HbA1c close to 2.53 initially. If you are giving those who are having baseline HbA1c 9.5 or 10 from the beginning. But of course, if someone is already a diabetic on some OHA, addition of DAPA, probably a reduction of HbA1c is hardly 1% is there. But if someone is having a newly detected diabetic, baseline HbA1c 9.5, 10, even if with a DAPA metformin combination, can well come down to less than 7.
Okay, then what's happening to
Sorry to interject. Sorry. I think we should answer that question after looking at the cluster talk. And then you have a good answer to that.
I was about to ask you the same question, Anjana, but we'll wait for your talk. Then what's happening to the poor DPP-4 now? Everybody seems to be living out DPP-4s now. I mean, where do they fit in a person with type 2 diabetes in India now?
Sir, actually, if you'll ask me, the DP4 is a medicine which can be prescribed in telephone. No need to see the patient. No need to see the patient's GFR, no need to see anything. But that is not true for a sulfonylurea, that is not true for also for SGLT2 inhibitors. So that is the place where DP4 is there. If in this telemedicine, those who are telemedicine not directly touching the patient, not directly seeing the patient, probably DP4 has some role in those group of patients.
Okay, now we have one more indication, telemedicine for linagliptin. Yes, Vijay.
One more thing, I think every molecule has got a role. I feel that I always believe in that, every molecule that is available in the market is useful for us. The only thing is, it is our duty to use the right molecule for the right patient at the right time. And I think that's when it makes a difference. I think with experience, people do develop where to use what molecule is to be used. Because in fact, I agree with Dr. Abhay Kumar as well that, it's a very safe combination, metformin and DPP-4 inhibitor combination. Because if you look into the way it works, this combination of metformin and incretin-based therapy will address most of the most of the pathophysiological factors in the woman's octet that we know. So that's one thing which we need to look into that. Except for the renal tubule action, the rest of the things, most of the 6 or 7 pathophysiological factors, this combination addresses. Now the whole thing is that the philosophy of treatment of diabetes is changed. We are no longer treating hyperglycemia. We are trying to treat pathophysiological factors which cause hyperglycemia. So I think we need to address more and more pathophysiological factors. In that sequence, we have to avoid hypoglycemia and weight gain, and that will be the best combination for a patient. So I think every molecule has got a role, including alpha glucosidase inhibitors. They are very effective in our population. They can bring down HbA1c to 2 to 2.5, as like Professor Abhay said that even the DAPA can bring down the HbA1c to 2 to 2.5. Even in Indian people, alpha glucosidase can bring down. Whereas if you look into the textbooks, it just brings down only about 0.5 and not more than that. That's what you said.
Correct, Vijay. So thank you so very much, Abhay. Thank you, Vijay Kumar, for that wonderful session on DAPA and sulfonylurea. I can see the stalwarts of the next session already getting ready, and I can also see, I think Sadashiv Rao, I can see him on the screen. I don't see
Sai is not there today.
Sai is not there.
Kalyan is there. Kalyan is there.
Yeah, Kalyan is the speaker. I think without wasting too much of time, Dr. Sanjay Reddy will take over along with Sadashiv Rao. Thank you, Vijay. Thank you, Abhay. But you are most welcome to stay back for this session. Yeah. And Anjana has challenged all of you that she is going to tell us what is the drug to be used after a cluster talk. For that, we should stay back.
Okay. Thank you, Dr. Arvind. Thank you, Dr. Vijay Kumar, Dr. Abhay Sahu, for this for a wonderful discussion. But I would like to take to the next session. I would invite Dr. Sadashiv Rao. Dr. Sadashiv Rao, Dr. Sai is now joining us as Managing Director of Elamanchi Hospital and Research Center, one of the senior most diabetologists in this country, to preside over the next session. The next session is there evidence for cluster-based therapies, pathophysiological-based choice of therapies, or computer-based choice of therapies? Now, there was a lot of discussion which went on in the earlier symposia. I think this also will add to this, and probably we get a clearer picture out of this. Over to you, Dr. Sadashiv Rao.
Yeah, good evening, and at the outset, I would like to thank the organizers of ADA Premier for giving me this opportunity. And today we are going to have a wonderful session here, and we are going to have wonderful speakers, especially Anjana does not need any introduction. Can I have the slide, please? Anjana. So Anjana, as all of you know, she is the managing director and diabetologist, Dr. Mohan's Diabetes Specialty Center, vice president of Madras Diabetes Research Center, Research Foundation, and her work is well known. And today, without wasting time, I would like to invite Dr. Anjana to give her talk on cluster evidence for cluster
based therapies.
Yeah, cluster-based therapies. Please, Anya.
Thank you very much, sir. I'm just going to start. Can you see my screen? Can you see my screen, sir?
Yes, yes.
Okay, wonderful. Let me just make that full screen. Yeah, can still see, right? Yeah, wonderful. So, good evening, everyone. It's a cool, rainy evening in Chennai. And I'd like to thank Sanjay Reddy sir, Arvind sir, KS sir for giving me the opportunity to be here. It's always a pleasure to be at Primer. We usually have the lovely opportunity to have coffee with all of you in Bangalore. But today, virtually, we'd like to, again, share coffee maybe and discussions after this. But today I'm going to be talking about, is there evidence for cluster-based therapies in type 2 diabetes? And I have no conflict of interest to declare. So it all started off, this whole clustering business started off when Leaf Group and colleagues asked the question, are all type 2 diabetes the same? And they came to the conclusion that obviously not. There's very different types of type 2 diabetes based on age of diagnosis, BMI, and complication risk, etc. Not everybody behaves the same way. So then would it be right to say, give metformin to everybody? And can we do the therapy that is universal for everyone? So what they did from the Scania cohort, they studied about 8,000, 9,000 people. They had 6 variables, the GAD, age of diagnosis, BMI, A1C, HOMA beta, and HOMA IR, and they divided or clustered all of diabetes into 5 subtypes. Now, one, which is called the SAID subtype, is type 1, and we're not going to be talking about that further in this talk. However, in type 2, there are 4 types, the SID, severe insulin deficient diabetes, the insulin-resistant SERD, the obesity-related MOD, and the age-related MARD. So these were the 4 subtypes which the Scandinavians described. The obvious next question was, could this be then applied to the Asian Indian population? Now, as you know, Asian Indians have a unique phenotype. So we talk about the thin fat Indian. We have lower age of onset of type 2 diabetes. So we have data from INDIAB and several other studies showing that the age of onset in the Asian Indian population is shifted to the left by at least 2 decades. At the age of 25 to 34 years, we start seeing diabetes, and even younger. For those of you sitting in clinic, we know that we have very young onset type 2 diabetes. We also have a lower BMI. So you have very thin BMI, people having a diabetes without much insulin resistance. We also have a characteristic dyslipidemia of low HDL, high triglyceride, high small dense NDL, decreased levels of adiponectin, more visceral adiposity, inflammatory markers. Suffice to say that there's increased prevalence of type 2 diabetes and premature cardiovascular disease. So this is a collaborative study called the INSPIRED study, which is a collaboration between the University of Dundee, Scotland, and the Madras Diabetes Foundation, which is funded by NIHR UK. So this is what we did. The first thing we did was to study Leaf Group's cohorts exactly as it is in the Asian Indian population. So we had SID, SERD, MOD, and MARD, like I said before. But the problems were many here. For example, if you looked at the HOMA beta and the HOMA IR, for example, they weren't exactly sitting as you would expect them to. So the first part of the first part of the slide talks about Leaf Group, how obese people were the most obese, the insulin resistant were the highest with the HOMA IR, and the second part talks about applying the same categories onto the Indian population, and there are some problems here. For example, the obese group were not very obese. The BMI was only 25, if you can see in the MOD, whereas the SERD group had much more obesity. And similar things like that, we could see overall the HOMA beta was extremely high for the MARD group. Suffice to say that that clustering wasn't sitting well in our population. So we then went on to say, okay, what if we did our own clustering? And that is when we came up with this publication in July 2020, where we looked at novel subtypes of type 2 diabetes. The base populations for this was 19,000 individuals that came out of the Dr. Mohan's clinics. The clustering variables were the following 8, the age, BMI, waist, A1C, triglyceride, HDL, and C-peptide. And you can see this is based on the Asian Indian phenotype. And these were the clustered subpopulations which we saw. So we had the SID, which is the severe insulin deficient diabetes, just like the Caucasian ones. We had the MARD, which is also the age-related diabetes, similar to the Caucasians. But we had two novel clusters, which were called IROD, the insulin-resistant obese diabetes. So what we were showing is that in our population, obesity is going very closely with insulin resistance, whereas these were separated out in the Scandinavian cohorts, ours seemed to be clustered together. So the obesity and the insulin resistance kind of went together. And then we had a new cluster, which was a combination of insulin resistance and deficiency called as SIRD. And we'll talk about this in a minute. So now if you remember the previous one, so the age of diagnosis here is kind of young, even for the MARD. So when you say age-related diabetes, this was a rather young population, 50, 55 years was young. As you remember, everything is shifted to left for us. So younger people were in this category. Now, if you look at the clustering, BMI and waist are lowest for the SID, the thin ones, highest for the obese, insulin-resistant IROD ones. Hemoglobin A1C was highest in SID and SIRD. These are the insulin deficient varieties, and the HDL was highest in the MARD category. So it seemed that, and you look at C-peptide, you'll see it's lowest in the SID and highest in the IROD, which is what you would expect. So we were able to get 4 clusters, which were kind of clearly defined. Now, when we started with this data set, we used new onset diagnosis of diabetes within 5 years of diagnosis. We also did sensitivity analysis at 3 years and 1 year and found that the clusters were pretty much the same. The next question then is, okay, this is a clinic-based clinic-based study. How does this apply to the whole country? And thus, we took the database of the ICMR INDIAB study. We had the following 6 variables, except C-peptide, we had all the variables which we used for clustering, and then applied this onto the INDIAB data set. And this is what we found. Now, again, MARD was 55 years age of diagnosis, the waist and the BMI lowest in the SID, highest in the IROD, A1C, it's all pretty much exactly the same as it was in the other two, other clustering that we saw, with triglyceride and HDL behaving the same way. So we were able to replicate this in a nationally representative database with the Jacquard Stability Index of 0.75. So however we looked at it, if we looked at it by males and females, urban and rural, whatever we did, we found these clusters clearly separating out. So what is the clinical relevance of this? We have 4 subgroups. Do they matter? Well, they do, because the prevalence, or these are the Cox hazards ratios for various microvascular complications here. So this is retinopathy. Nephropathy here is the proteinuria, both micro and macroalbuminuria, and CKD is the GFR linked one. So now if you look at the risk or the hazards for retinopathy, SID had the highest, as you would expect, but it's also quite high in the SIRD. So this is a combined group that we were talking about. Now, what about nephropathy? Again, the highest is for the SIRD, so the combined one has come here as well. And even for CKD, along with IROD, you have a very high hazards in the SIRD group. So look at this combined group. Now, the prevalence of this group is not so much. So not many people have it, but those who do, it's important that we identify them early because of the risk of both retinopathy and kidney disease. So you can see the microvascular these are people who progress very fast and perhaps need early insulinization. So So now we come to, okay, we describe some people, they have a particular risk of, microvascular complications. Are there differences in prescribing patterns and difference in treatment? The one exactly that we were talking about, is metformin the drug of choice for all these groups? And this is a study we did. It's a retrospective analysis. Unfortunately, it's not an RCT, which can give you clear, finite outcomes. But this was a retrospective, real-world study, which was done in 15 clinics. The who's who of diabetes here. We have many people here also part of the team that gave us data. So we had 32,000 individuals in the study from every part of the country, as shown on this map. And I'm not going to take you through the same tables again and again, but suffice to say, we were able to replicate almost exactly up to decimal point. The 4 clusters came out clearly in this population as well. But now what I want to talk about is the drug response. So I told you we had 32,000 individuals. We had baseline drug data available in 30,000 of them. Then we needed a follow-up A1C, because we're looking at each drug and how the A1C is responding. We had that in 14,000. Then we had to see whether they're drug naive at baseline. So these were new onset diabetes. Remember, it's not an RCT. These were people who had just come into the treating clinics. So someone could have new onset diabetes, but had already been started on insulin or a drug outside and then came to us. So if they were new onset, there were so many. If they already had, we had to then see whether there were changes at baseline, which could be attributed or followed up with the A1C. And finally, for this analysis, we had 13,000 individuals, which we could look at. Now, these are the drug prescribed patterns in the population. So nobody, when they were prescribing, nobody knew that they were SID or SERD or IROD. These are all just type 2 diabetes, walking into various clinics, private practices across the country. And what is the drug response? We have now put them into these categories among clustered individuals and seen what kind of response we're getting. So overall, if you look at it, traditional agents. So sir asked, would you use sulfonylurea? Would you use metformin? Most people are still using sulfonylurea and metformin. That's 25% of all practitioners. New onset diabetes, high A1C, straight away it's a combination of metformin and sulfonylurea. That's what people are doing. Plain metformin is coming lower down. And among the newer agents, we're not yet there with SGLT2. As you would expect, it's a new drug, but DPP-4 does seem to have an age advantage over SGLT2 at this moment in time. So that's what this slide shows. Now, if you look at the drug responses, now here what we have done is that we have used metformin as the base. So what does it say? It says give everybody metformin. That's what all the guidelines say, right? So over and above metformin, are there in each cluster category drugs that are doing somewhat better in terms of bringing down the A1C? So obviously insulin does better in each group. So I've shown first the insulin deficient categories, that is the SID and the SERD. And you look at the SERD, the responses to insulin or anything else appears to be much, much more profound in the SERD group as compared to any other group. But SID also had a good response to insulin. And after that, you'll see that sulfonylureas actually do well. Sulfonylurea and DPP-4 does well. Whereas in the SERD group, we'll also find TZDs doing quite well. So already you can see just from an intuitive aspect, the ways clinicians are treating are already somewhat within our cluster categories. So similarly for the IROD, now here, obviously insulin did better, but not many of the other drugs were over and above metformin. So here maybe metformin is the drug of choice in this particular category. Whereas in MARD, you'll see that even insulin didn't have a great effect. All of these drugs seem to be doing, whatever drug you gave worked quite well. This is a mild age-related kind of disease that was responding to any of these drugs. So now people ask, okay, what is it that is, how do I use this in my clinic? If there is a type 2 diabetes patient, new onset coming in, how do I use it? So we've developed this tool that's called Diana. It stands for Diabetes Novel Subgroup Assessment. And this is how it works. So all you got to do is fill in these categories. You don't need all 8. Okay, you can manage without 6. So it will ask you to predict. Once you just fill in age, BMI, waist, etc., and it will give you an assessment like this: SID, so much percentage probability of retinopathy, so much percentage probability of DKD, and what is the suggested medication for your patient. So this is the new Diana app that we are currently validating. Can be used in a clinic, in any GP clinic. Fill in 6 not very difficult to find indicators: A1C, waist, BMI, age, etc., and you're going to start getting directionally where you need to go with these patients. So in summary, for the first time in South Asia, we've redone the clustering of new onset type 2 diabetes. We had 4 replicable clusters, which were stable across different populations. 2 of these were similar to the originally described clusters. However, we do have 2 unique clusters, the IROD and the SIRD. The SIRD is of importance because it has difficult to treat hyperglycemia and increased risk of microvascular complications. As response to drugs, we still have a heavy usage of traditional anti-hyperglycemic agents. Newer ones are yet to come in. And even in the distinct phenotypes, we can see some forms of therapy are more effective in some groups of patients. So someone was mentioning before, giving the right patient the right therapy at the right time. I think this is an important first step towards doing that. However, I must say again, randomized clinical trials are needed. These are only indicative data, and this is retrospective. It is largely driven by the baseline A1C at the moment. We do need larger trials to confirm these. Thank you very much.
Thank you, Anjana, for a wonderful lecture. Really, all this cluster-based therapies. I think the questioning is after all the talks.
Yes. We will take the questions at the end of all the questions. Yeah. So we can invite the next speaker. The next speaker for today for this Dr. Kalyan Gangodhar. Can I have the Dr. Kalyan's CV, please? Kalyan Kumar Gangopadhyay is an MD, MRCP, CP, and a CCST graduate from London. Who's practiced sometime in the UK. He's a consultant endocrinologist at CK Birla Group of Hospitals and Peerless Hospital, Calcutta. Dr. Kalyan is going to speak on pathophysiology-based choice of therapy. I request the RX event guys to allow his video to be played. Over to you, Dr. Kalyan.
Thank you very much, Dr. Reddy. I hope you're well. Haven't seen you for a while now.
Neither me. I've not seen you.
Okay, so let me share my screen because my video was switched off. I think you have to just bear with me for a few seconds while it uploads, and then I'll share my screen. Okay, so I'm going to share my screen now. Please tell me if you can see it clearly.
Yeah, you can see it. It's fine.
Okay, fine. Yes. I'll put my timer at 19 minutes and 20 seconds so that I finish on time.
Thank you for being
okay. So, is there evidence for pathophysiology-based choice of therapy? We heard an excellent lecture about the cluster-based, and this was the Indian version of the cluster-based was new to me, so it was a refreshing change from hearing just SGLT2 and DPP4 in and out every day. So that was a refreshing change. So we talk about pathophysiology-based choice of therapy, and G. Vijay Kumar had alluded to that. So is there any evidence? So I'm going to put some evidence in favor of that, and then I'm going to raise some controversy as well. So acute insulin administration. So we heard about many patients present to us in a catabolic state with weight loss, more than 5%, and with quite severe osmotic symptoms. We then say that they are at insulin deficient stage, in glucotoxic stage. So we need to get the sugars down acutely by using insulin. Now this is the famous DiFronzo lecture in 2009, where he had said that when you have impaired glucose tolerance, you have already lost about 80 to 85% beta cells. I'm going to refute that in a minute again. But for now, so if we are losing 80 to 85% of beta cells at impaired glucose tolerance when you have got diabetes, it's probably much more. So pathophysiologically, it makes perfect sense to initiate on insulin. And this was the earliest data, which is very well-known Weng data, where patients were started either on OHAs only, or on multi-dose insulin only, or on continuous subcutaneous insulin infusion. Once their glycemic control was adequate, everything was stopped and followed up after 1 year, and wherein it showed when normal glycemia was maintained for 2 weeks, treatment was stopped, and after 1 year, it's a brave study to do. You are stopping treatment altogether, and at the end of a year, the patients who had continuous insulin infusion, 51% were in inverted commas remission of diabetes, whereas it was 45 in multi-dose, and only 26% of those patients who had oral hypoglycemic agents were in remission. So all in all, the pathophysiological basis was that you are insulin deficient. That's the main pathophysiological problem. You're giving the insulin back, reducing the glucotoxicity. That is what keeps the beta cell alive. So there were multiple studies after that from 2006 to 2013, wherein several ones showed that after short-term intensive insulin therapy, there seems to be quite good beta cell function. And there was a systemic review and meta-analysis of all these studies, which showed that the HOMA-B with the insulin secretion was clearly more in those patients who had early intensive insulin therapy, and the insulin resistance was reduced in those who had early intensive insulin therapy. So far, so good. It seemed, oh, that's very clear. We don't have anything else to do. That's it. That's the pathophysiology. Insulin beta cells are dead. You're not making insulins. Give insulin. That is the answer. Now, is it so? Is it really beta cell death? So now, you see, for me, if an agent prevents progression from impaired glucose tolerance to diabetes, so as I said, from the DiFronzo model, you have got 80% beta cells are out, dead, when you have impaired glucose tolerance. So if you can prevent this from IGT to diabetes, I think that agent would be preserving the beta cell. For me, that makes perfect sense. It makes perfect pathophysiological sense that the drug which prevents progression from IgG2 to diabetes is the drug which preserves beta cells. So I've talked about the insulin. So the pure insulin trial, which was the origin trial, wherein you had patients with high CV risk where we're given standard glycemic care, or you give only insulin. And herein you had a number of patients who did not, or you had impaired glucose tolerance. So therein, about 1,500 patients without diabetes at baseline, there was a 28% reduction in progression to diabetes. Now, if you see here, that 28% reduced to 20% after the second OGTT after a gap of 3 months. So that was a little bit surprising. If we are saying that insulin is the all and the answer to preserving the beta cell, why was there only 20% reduction in progression to diabetes from IGT? Shouldn't it be a bit more? So we recently have the RISE study. I say recently, it's almost 3 years. So diabetes in youth, IG, impaired glucose tolerance in youth, or recently diagnosed type 2 diabetes. We have about 90 pubertal overweight 19-year-old patients with 60% who have IGT and about 40% who have relatively new onset of type 2 diabetes. So here you divide into glargine, 2 groups. One group received glargine for 3 months and then metformin for 9 months. The other group, you're given only metformin. So then you see what happens to the beta cell at 0 month, at baseline, and then at 15 months when you have stopped treatment for about 3 months. So what happens now? if we are saying that the insulin is the one preserving the beta cell, then you should have a better result here. But actually, in fact, if you look at the BMI, if you look at the HbA1c, it is kissing each other, so it means there is no change. If you look at the fasting sugar, actually, it's better with the metformin alone arm. And if you look at the 2-hour blood sugar, it is the same. So actually, giving the insulin for the first 3 months didn't seem to make an impact. So you have got bariatric surgery here. Now, this is an analysis of more than 1,600 patients who had bariatric surgery, followed up to 15 years. And patients who did not have diabetes at baseline, there was a 78% reduction. Here, you're not giving any drugs. There was a 78% reduction in progression to diabetes. And those who had impaired fasting glucose, you had 87% reduction in progression to diabetes. So that's a whopping reduction. So where did the beta cells go then? We have just said the beta cells, 80% of them are dead. And now you have reverted back into normal glycemic control or prevented progression without giving any drug. Now, this is the summary of all the drugs which have been used in IGT and how much they have reduced to diabetes. And you can see here, in here, and here is the insulin, which is 28%. It is actually at the bottom almost. So the best is the glitazone group, which is about close to 75%. And least is the acarbose, and insulin is just above acarbose. So that's surprising. So therefore, it must not be that the beta cells are dead, but the beta cells have de-differentiated. So all in all, they might be moving from one area, one cluster to the other. We don't know. We don't know. There's no basic proof of that, but that's what we can hypothesize. So DeFronzo had come up with the ominous octet of all the pathophysiological areas which needed to be targeted when you are treating diabetes. And of them, I will come to this one first, which is increased hepatic glucose output, which is one of the important pathophysiological mechanisms of blood sugar production excess. And you can see here, this is one basal hepatic glucose production in control arm and type 2 diabetes arm. Clearly, it is more in type 2 diabetes, and clearly that is reflected in high fasting glucose. Pathophysiology base, if we are talking about, so why is metformin given? So metformin is given because this is one of the important pathophysiological defects, and metformin targets exactly that. So that's another area for the pathophysiological defect. Now, improving or increasing the insulin sensitivity. So this is the Today trial wherein, see, this was again done in youth, in young adults. So deterioration in beta cell function in youth appears to be accelerated as compared to that in adults. Here we had about 700 patients who were randomized to either, relatively newly diagnosed diabetes, who were diagnosed, randomized to either metformin or metformin and lifestyle, or metformin and rosiglitazone. And they performed analysis of insulin, glucose, insulin, and C-peptide, basically to see the insulin sensitivity and how much they can hold on to the insulin. So metformin, metformin plus lifestyle, and metformin plus rosiglitazone. So we can see here the metformin, this blue is metformin alone, green is metformin plus lifestyle, and red you can see metformin and rosiglitazone. Clearly, the insulin sensitivity is addressed better. So of the many pathophysiological defects, the glitazones seem to put a tick box on a few of, on quite a few of them as far as insulin sensitivity is concerned, and which is reflected here that the metformin and the rosiglitazone had about 38% of them had failed, whereas in metformin alone, more than 51% failed. So clearly, that seemed the insulin sensitivity increase did work. So that's correcting the pathophysiological defect did work. So using two agents now, increase hepatic output, reduction in the hepatic glucose output, and improving the insulin sensitivity, that works even better than metformin and lifestyle. So if you look here at the trials with the sulfonylureas, there is a 90, which after the glucose level going down, it again goes up. But with the glitazone-based therapies, there seems to be more of a flattened line indicating the sustained improvement in the glycemic control as part of maintaining the insulin sensitivity, which I've just shown you. So therefore, I've shown you patients who are catabolic state, they are insulin deficient, you need insulin, there is the evidence for that. Hepatic glucose production, metformin, evidence for that. Insulin sensitivity needs to be improved. So you have got evidence for thiazolidine dance, which I've just shown you. But trying to get all of them together, so multifocal approach, just like in TB or in AIDS, use multiple drugs to target one pathophysiological condition. Here also we must remember diabetes is just like TB or an HIV. You need multifocal approach. So here, I think EDIC trial, a lot of you know by now. So we have the initial combination therapy with metformin, pioglitazone, and exenatide, which is a GLP-1 receptor agonist. So now you're ticking the boxes of a lot of the pathophysiological defects. So this compared to sequential add-on therapy, which we are used to, and we're still doing, starting one drug and then going on to another one and then going on to insulin. This is the EDIC trial, which I think is really an eye-opener. So here, if you add triple therapy, if you start triple therapy right at the beginning, this is the HbA1c drop you get in patients who have got high baseline HbA1c. You get no weight gain, whereas you get it with the sequential, and you get 3 times less hypoglycemia. So overall, over a period of 6 years, with the triple therapy, the HbA1c is maintained, and there is a flat line which is maintained for a long period of time. So you're maintaining a flat line as far as HbA1c is concerned, without increasing the hypoglycemia and not causing weight gain, rather causing weight loss. So this is what the pathophysiological based approach does for you, because you're ticking all the right boxes. At the end of the day, patients come to us with the hope that their glycemic control is maintained for a long period of time without increase of hypoglycemia, without weight gain. So this is what answers most of those questions. Not only that, and the EDIC trial, which I've shown you here, is relatively newly diagnosed diabetes. In the Qatar study, where patients were almost 10 years into their diabetes, their patients were already on sulfonylurea and metformin. Here, they added pioglitazone and a GLP-1 receptor agonist. So again, ticking all the boxes of the pathophysiology in diabetes, or you add just insulin. So what this clearly showed here is the diabetes duration, which I was talking about. So you can see that they're not newly diagnosed for 10 years. And look at the baseline HbA1c. So here, and there were a few number of Asians. I accept the point that the numbers aren't huge. But what I'm trying to tell you is that if you start it right at the beginning of diabetes, it works, which I shown you in the EDIC trial, and in the Qatar trial, even well into their diabetes, if you tick all the pathophysiological boxes, a correct pathophysiological approach, then also it works. And here it shows that the HbA1c drop is better and sustained with the combination therapy, even with high HbA1c levels. And this you can achieve with less than 3 times of hypoglycemia. That is what we want. So I've got about 3.5 minutes more left. So the incretin effect, now we know about that if you give glucose orally versus you give glucose intravenously, there is a gut factor which is responsible for the hepatic glucose uptake and the insulin production. and we later identified that as the incretin-based therapies. Now, in the recent VERIFY trial, they had suggested that there was a 49% reduction in risk of time of initial treatment failure if you start the incretin-based therapy with metformin, and there was a 26% reduction in secondary treatment failure. However, if you look at the Indian sub-analysis, these figures were 53 and 58%, so more. So we seem to do better as far as the incretin-based therapy is concerned. So there must be a pathophysiological reason for that. This is the HbA1c reduction amongst non-Asians as compared to Asians. Two separate meta-analysis mirroring the same, almost double, or if not more, the HbA1c reduction. And this I had seen while working in England. I worked in Birmingham, where there was a big Asian population, and I could see that there was a clear reduction, which was in the Asian population, which wasn't there in the Caucasian populations. If you ask an American doctor, they will say that DPP-4, it will be 0.5% reduction. But I could see a big change amongst the Asian patients. So our pathophysiology might be a bit different. So we have to address those when we are dealing with our Indian patients. So this is the DPP-4 protein. Now this is the soluble DPP-4, and this is the membrane-bound DPP-4. Now the membrane-bound DPP-4 is unlikely to cause any problems. It is the soluble one which is going to cause problems. So if you convert these membrane-bound into soluble, then that means trouble. So we don't want that. So there is an enzyme system called KLK5 in the lymphocytes. Lymphocytes are a big source of DPP-4, which cuts this membrane-bound and converts into soluble. So what it showed in one of the articles by Shotinath Mukherjee, that not only was our DPP-4, soluble DPP-4 higher in our newly diagnosed type 2 diabetes patients, but here the KLK5 enzyme was more active. So we were cutting the membrane-bound and converting into soluble. So I'm not saying that is the reason, but this could be one of the reasons why the DPP-4 seems to work well. When I put this question about a newly diagnosed diabetes without osmotic symptoms, having HbA1c of 10%, which drug would you use to many delegates? The answer was DPP-4 metformin, because there is a whopping drop in the HbA1c with newly diagnosed diabetes when you use DPP-4 metformin combination because of this reason, which I've seen in many Indian patients as well. So this is the one with, I've shown you one with sitagliptin. This is one with linagliptin. High baseline HbA1c, newly diagnosed, you get a very big drop in the HbA1c without increase of the hypoglycemia. So I think I've got 30 seconds more. So in summary, I think I've shown you evidence for acute insulin administration, patients who need it, osmotic symptoms, weight loss more than 5%, they need their insulin deplete, they need insulin, you've got evidence for that. You've got evidence for hepatic glucose production in the form of metformin. I've shown you with thiazolidinedone, the insulin sensitivity. I've shown you the effect on the Asians with incretins, and I've shown you evidence for multifocal approach, ticking all the boxes. So the bottom line is tailor it to the patient in front of you. So I've just finished on time. Thank you very much, and I end here.
Thank you, Dr. Kalyan. That was really a nice presentation with all the facts laid in front of us to decide what we want to do. Please stay back for question and answers next. Dr. Sadashiv, sir. Now, yes, we have the next talk by Dr. S.V. Kulkarni. Can I have this intro slide, please? The topic is computer-based choice of therapies, artificial intelligence, or can computer aid us, or technology aid us in probably choice of therapies. So it's a general physician and internal medicine specialist at Om Sanjeevani Hospital and Fortis Hiranandani Hospital, Navi Mumbai. Over to Dr. Kulkarni, sir, for your presentation.
Thank you. I need my permission to share the screen.
I think, please.
my audio?
Sir, your audio is okay, sir. Perfect.
Okay, absolutely.
I think you can see. Yeah.
So thank you, organizers, for such a wonderful opportunity, and I'm really very happy to be part of this symposium. ADA Primer. Is there evidence of cluster-based choice of therapies, pathophysiology-based choice of therapies? And I'm going to talk on computer-based therapies, which are aided by AI and machine learning. Friends, it looks to be a bit odd topic. I'm a primary care physician. I have seen diabetes evolution for last 41 years from the time of DBITD, tolbutamide, and the Boots porcine injection to the amount of AI what we are using today. And that's a big passion as far as my interests are concerned. So there are no conflicts of interest. My flow presentation is going to be the brief introduction of the new terms, what we use here, how they interact with each other, what are the practical examples, utility, what are the use of connected equipments in day-to-day practice. I am talking for the Indians of Bharat. In India, where they stay in small villages, small cities with a restrained socio-economic status. I'm going to put you on evidence and I'm going to tell you what are the different kinds of ways in which you can go forward. Just a question, is it a very high funder rocket science? Sir, no, but it is a bit out-of-box idea. It's a new tool of integration using what we have in our clinical setup. We are doing it, but we are not applying it. Example, patient data, machine inputs, aided therapy, and the therapy choice. We improve our practices, like we should make it data-centric. So what we are supposed to do, now everybody is using telemedicine or the electronic health record. We have got online communities and social media. We are using all wearable sensors and devices, and there are smartphones and apps with e-health records. We can definitely improve our outcome. Is it going to replace physicians? Definitely no. There are various definitions and various things which are related to AI, but I will just like to highlight, it's a broad term. I will not call it as artificial. We are all intelligent. It is augmented, assisted, or amplified intelligence. What it does for us, it enhances our visual perception, speech recognition, decision-making, data compilation, analysis, and translation between the knowledge. The language barriers are going to go off. It can be simple as rule-based, or it can be a complex statistical method. But the capacity of analysis is absolutely enormous. One of the best example is Watson in oncology. So just for my grandchild definition, AI is to sense, reason, act, and adopt like humans do, or in ways beyond our abilities. We cannot match the abilities of AI. What are the components of AI? There is some systems called as the machine learning, NLP, natural language processing, artificial intelligence, human interaction, reasoning. But of all the things, what you see is that AI ML tools are used in all scientific fields and revolutionizing their business except healthcare. So it is an orphan tool and we must use it. What are the applications in healthcare? Its ability of a machine to perform a task that mimics behavior, including problem solving and learning. In diabetes, I can say how you quantify exercise. It can be used for range of purposes, automatic tasks, and in healthcare, we use an image analysis such as radiology or ophthalmology, and it has provided fantastic results. It gets analysis of data from wearable sensors to detect diseases or infer the onset of other health condition or the complications. These are the three components of AI. The first thing is called as the deep learning, second is machine learning, and the outer core is AI. Machine learning represents a shifting medical clinical paradigm from rigidly defined management strategies to data-driven precision medicine. This P is really very important, and it is where we are going to take you once we learn more about this technology. Machine learning is nothing. It is just a pattern recognition. You have got 1,000 cats in a room and there is only one tiger. It will recognize the tiger immediately. It is just by pattern recognition. It provides systems the ability to automatically learn and improve from experience without being explicitly programmed. The machine learning can be supervised, unsupervised, semi-supervised, or reinforcement-based. What my Fitbit uses is by reinforcement-based machine learning. They emulate human intelligence, and there are certain other different kind of terms which the computer people will bombard on you, but you safe way ignore to them. So what are the several, these are AI-based techniques. One is called as a case-based reasoning or CBR, ANN, artificial neural network, support vector regression, that is SVG, and with just combined with case-based reasoning, clinical decision support. What Anjana was saying, that if you combine this even in any small practice of 1,000 patients, you can have a fantastic record with you. And predictive population risk stratification. I will recommend everybody this one article which has been published in August 2020 is the AI, the future of diabetes care. It is really a very good way to show how the future is going to be. So these are the different kinds of models and everything which are using in type 1 diabetes. Let us not go into the detail, but here if you can see the word hybrid, that is the way in which a glucometer will communicate to the machine or to the sensor to deliver a right dose of insulin. So this is another buzzword called as IoT, Internet of the Things or Internet of Medical Things. And the variables are the key word of today. And the human being can have so many variables. There will be a lot of data out of it. And the data is the currency of future, and there are algorithms like IBM Watson or other which are going to analyze, and they are going to help us for the precision type of medicine. What is IBM Watson? It replicates humans' ability to answer questions. It has got 90 servers with combined data of 200 billion pages, and it helps you to predict, shape future outcomes, automate complex processes, and optimizes your stress and strain. Ultimately, what is the end results of this kind of precision medicine is development of medical devices and systems for advanced medical services. Means a personalized medicine, a particular medicine without any side effects. So the patient is at the center. You have got all the technologies with you, and you are going to give a big outcome. How machine learning can help in management of diabetes, IHD, obesity? It predicts risk of diabetes based on the genomic data. We will come to it soon. From the electronic health data to predict risk of complications like nephropathy, retinopathy, and diagnosis of diabetic retinopathy. This is one particular area where there is a huge amount of evolution as far as detection of diabetic retinopathy at earliest. But what we need structured data. We need proper diabetic records for our patients. Now come to glycemic control using smart pens. This is a concept called as a machine-to-machine dialogue. There is a talk, machine-to-man talk, man-to-machine talk, and machine-to-machine talk. Here, the sensor is talking to the pen and it is advising you the sugar. What is the dose of insulin which has to be given? It largely pertains to the artificial pancreas system. And there are a lot of studies using different approaches have tried to automate the insulin infusion on the basis of CGM data to suggest the insulin bolus dose, or there can be prediction of glycemic events or hypoglycemic event. This you might have seen in so many conferences abroad. This is a concept called as a hypoglycemia simulator. We can predict impending hypoglycemia or hyperglycemia on the CGM data along with your Fitbit data. So important high-risk professions like drivers, pilots, deep sea divers, and astronauts can be definitely helped by this. And there are new simulators. This is going to be the sixth sense of a doctor. Augmented reality, virtual reality, mixed reality, and immersive reality, which are going to be the part which is going to be aided. So let us forget the cloud and come down to your clinic. You will have such smart weighing scales, body composition analyzers on wireless data sharing. This is your famous CGMS data, which is going to be fed to your computer, and these are the fantastic future glucometers, non-invasive glucometers, even with HbA1c. This has got a combination of glucometer with CGMS and HbA1c analysis with a data like a activity tracker. Not only glucose, but you can have smartphone compatible BP instruments. This is a tubeless BP apparatus, and you can decide the dose of drugs according to the BP variation. AliveCor which takes ECG. These all instruments can be connected to the patient's EHR. But friends, type 2 diabetes is a challenge. It's more complicated than type 1. There are multiple treatment options that are to be added sequentially and incrementally. There are many factors: BMI, neck, waist size, underlying beta cell function, very beautifully explained by the previous speaker, insulin resistant, and among others. But what we need, the data, which is demographic, fixed, or there can be fixed data, there can be some variable data. You need to be input by the caregiver, input by the educator, the data from glucometers, activity trackers, food plate evaluation, and meal analysis. So we have to have intelligent, customized electronic healthcare system. Unfortunately, we don't have. There can be something like a logistic restriction that were applicable. Means suppose if the patient has got a history of congestive cardiac failure, and if you write pioglitazone in your prescription, the prescription may say that this drug may not be safe on this patient. Or to just give some few examples, we can optimize or automate therapy by machine learning algorithms at a patient level. If the age of patient is more than 70, 80, it will tell you avoid sulfonylureas. Diabetes duration, will need more drugs or watch for complications. With high BMI, metformin, SGLT2, central obesity, same acanthosis nigricans, you add pio, limited joint mobility, you have got HCQS, DEXA circumference high, you have got OSS to be suspected. In case of edema, you avoid pioglitazone. The same way in continuation, irregular meal patterns. Mumbai, we don't have fixed timing of meals, either voglibose or ripaglinide. And fast eating, there can be sleep disorder breeding or Chambers purpura. High fasting insulin, we can have only therapeutic lifestyle monitoring. High normal C peptides, we don't need insulin. LFT distorted, charger. LFT distorted, we need dose adjustment. RFT distorted, we know recalculation, and GI upsets, whether upper or lower, we need to avoid metformin or AGIs. Can we have something like a pharmacogenomic evaluation data? This tells about potentially impacted medications. What is the category, class, standard precaution, and drug-induced weight gain of olanzapine in diabetic patient can be done. And this is actually a summary of pharmacogenetic test summary of the patient. What is the thrombosis risk? And if it can be done for anesthesia, if it can be done for other things, why not for the 7 classes of OHA? So I'm just coming back to the same circle. If we can help in this, and if we can put on your data, definitely it will be helpful, especially for young technology, young techno-savvy type 1 diabetics. This is a few references: computer vision based carbohydrate estimation for type 1 patients, where the patient can do a calorie counting very easily, or pattern classification and anomaly detection by an
hello. I think there's some problem with this battery which was dying. I could make out. So we can, in between, we have Anjana and Kalyan. So we can take some questions if there are any.
Well, Sanjay, I would like to say first that this is one of the adverse effects of computer-based technology.
That is what he was talking about. That is what he was talking about. So that is what was. Give me a minute. This is what that he was talking about. Yes, Dr. Krishna is here. You want to add anything on Dr. Krishna on technology and how it can impact probably treatment options, or whether it can do much more than that?
We don't have hardcore data, but we will get there somewhere, like our data which is coming in, and the way technology is being used, and the way number of
I lost my connection.
Yeah, we got you back.
I am back. I just take only 2 minutes to conclude with because I am at the fag end of the presentation, and I am using a double technology, a smartphone as well as on my laptop. I hope I am audible to all of you, and sorry for the interruption. So all these newer things are going to be a boon for the techno-savvy type 1 diabetics. There is an app called as the One Drop, which provides a very complete discrete solution, and there are going to be
not visible
apps and instruments which are going to come in the future. There is a concept called the digital twinning, in which you can have a whole body digital twin, which is a dynamic digital representation of human cardiometabolic function. There is certain definite evidence that a concept like retinopathy, which gives a specificity of 90% when the prevalence of diabetic retinopathy, and which we can definitely use in your clinical practice, and I'm sure all of the major centers are using this diabetic retinopathy screening. Diagnostic performance of deep learning based screening methods has been definitely evaluated in a very good positive way. Friends, how we can use AI ML in generating insights and specific solutions? Country of no records or lack of it, we should use electronic health record. The huge burden of disease can be transformed into opportunity. Entire data can be harnessed in a usable form, and there can be something like an Atom Voice, which is a neural network for clinical trials, which will facilitate us in getting newer drugs. And there is a deep genomics, which finds better candidates for and developmental drugs. But at the same time, there are limitations of this technology. Healthcare professional needs training and reinforcement for learning. We need dedicated, trained diabetic educators. We must know the recognized limitations also. Over-reliance may lead to descaling of a clinician. We'll always use human backup and touch-up. Data is currency of next generation. We need to generate, extrapolate, analyze, and reinvent our data. And we must start from simple to complex. Researchers often do not share their source codes or pseudo codes for competitive reasons. There are people who have got tall claims, immature, inexperienced clinicians, and they have very high cost of their technologies, and technical interoperability or ability of 2 or more systems to exchange or use the information is one of the biggest limitations. So friends, let us share some further readings and evidence enhancements of this AI and ML. But I just conclude that this is a technology which is going to be predictive, personalized, preventive, precise, pervasive, protective, and participatory. This is, you must be masters of the technology and not slaves of it. But we can give a wonderful diabetes control to all of your patients if you use this new technology, but which is not only budding, but it is going to get a great shape and reducing our burden. Thank you very much. I'm really sorry for the technological disruptions of it.
Yes.
Thank you very much.
I know the word today is disruption, is it not, in technology? If you don't disrupt, you do. If you disrupt, you survive. Otherwise, you don't. So that's what it is. And the whole world is disruptive. And then I have Krishna joining along with me with Dr. Sadashiv Rao, and then Anjana, Dr. Kalyan, and Dr. S.V. Kulkarni to say some, if we have questions. Both you, Krishna, and Dr. Sadashiv Rao for anything else. I think Anjana has a point. Go ahead.
When I see a case there, I have to ask a question.
What is it? Yeah, go ahead.
Sir, I'm going to ask you, with all these numerous things in technology, and all of us are dealing with all of this data coming in, I'm going to ask about patient security and safety. Because I have information coming in from a Fitbit, I have something coming from somewhere else. And as a doctor, I'm making decisions based on some of these, and I'm using external sources to help me. I'm obviously not, So what happens to this data? What if this guy sells this data to somebody else? And how do we protect ourselves? More importantly, how does a patient protect themselves,
Thanks, Anjana. I think Dr. Kulkarni is also here, so I will ask him also for his opinion. The important thing to remember is for the medical community to actually spend time thinking through this. We don't spend the amount of time we reinforce so many things. We don't spend time reinforcing the more important aspects of the art of the art of the science of the medical practice. That includes, importantly, how to handle patient data. The first thing is, I remember 15 years ago trying to get up a notice on the elevator saying, please do not discuss patient care in the elevators. I don't know if you remember seeing that little board at some point of time. But this is, as I've said in other places, that we are the last wall standing between patients and abuse. So we need to think through this. First is, give patients privacy in our clinics, not see more than one patient, not look at your phone. Remember that your phone listens. I don't know how many of you know that you have given permission for your phone to listen to your conversation. That is why when you go online, let us say you're talking about a trip to Timbuktu, you will get an advertisement from ClearTrip or any of the providers. So even our phones have devices. But what should a practitioner do as a start? First is, first document. Unless you write, you are in trouble. Second, slowly get into an electronic medical record. But when you do that, make sure that it is something that you buy, that you've invested, and that you know where it can be stored, and then that you can port the data. Third, think about, let us say a patient is moving away from your practice. Don't hold on to his data. That you actually tell the patient, look, I can provide this data in a format that is universally acceptable, and you should take it with you. So these are things that we all need to talk through, and the important thing is that we think that in things like these, the government should come up with ideas. No. Someone once asked me, why isn't I worked with the Medical Council of India before, and someone asked me, why isn't the MCI doing it or the universities doing it? And I keep asking, who makes up the MCI and who makes up the universities? We do. The more and more, Anjana, people like you and Sanjay and Kalyan and everyone else start bringing these up in forums and start forming guidelines of when it should be blockchain, to when it should be, what should be the encryption level. And we need to start collaborating. Unfortunately, I'm sure Dr. Kulkarni will add to it. All our technology solutions have been provided by the industry. They are not designed by clinicians. It's time that clinicians start doing this. It's a very important part of it. Thanks, Anjana, for putting me on the spot.
It's a problem we're having, sir. So we have our own EMR system. So all up to today, I know where the data is, and there is a privacy and a control. But today, when I'm seeing people approaching and they say, go through this app and this thing, and who holds the back end? They hold the back end. Every prescription of yours, everything that you're sending out, everything is with this guy, right? So anything that goes through, it's a huge issue. And I do know already there has been a transfer, companies, startups, pharma companies, there's all kinds of things going on. And doctors have no clue. They have no clue.
Absolutely. The most important thing is that if it has been offered free to you,
it is free for them, no? And
right? Then you know that there is no such thing as a free lunch.
That's what most people don't understand. That's a funny thing, and why is nobody asking, why is it free?
No, I don't know. Many people, first, implementing EMR is a big issue for many of them. They say that they don't want to disrupt the practice, as I said. If they don't disrupt it now, they'll be disrupted forever. Yeah. It is at some point going to become mandatory. But second, important is data security, as you told. So,
can I move on and ask a question to all the three of you? There are many approaches that people have taken. People have taken a genomic approach, which by itself has not worked. Some people have taken the pathophysiologic approach that itself probably has not worked. And now the people are taking the data approach to to sort for us. So from each of you, can I have a comment on the other two, so that how do we bring this together? How do you think in 10 years we are going to approach a patient through how are these various streams going to form the Ganges of diabetes care? Okay, Dr. Kulkarni, you start.
Yeah. First of all, I will definitely use the data mining, data technology, but form my own clusters of my practice. And in those practices, I will try to find out what are the pathophysiological trends. For example, if I got 1,000 diabetics for whom I have done a fasting insulin on them, and they are very insistently told that they have to have a therapeutic lifestyle monitoring without having any drugs, I think I have won the confidence of those people much better than that. But if I got a patient who is on 15-20 days long on diabetes, he's already on 4, 5 OHs, 6 OHs, and if he has got a low C-peptide, I am 100%, I have got no other alternative but to ask him for insulin. So in that way, if I can analyze a patient over a longer period of my continuation with the help of electronic health records, and if I get some of the inside information about his diet pattern, diet contents, there are a lot of Indian data banks which tell about the contents of Indian diet as far as carbohydrates are concerned. In Maharashtra, we eat 5 different types of carbohydrates. Everybody, all 5 of us who are seen on the screen will react differently to that. So in that situation, the big data or the data analysis of your food contents and your response to individual treatment makes a lot of difference.
No, so I'm just going to add a comment to this, and I'm going to pass it on to Kalyan. The important thing though is that when you have these kind of data, unless this is machine learning in work, I don't think the good old-fashioned step-by-step clinical pathway algorithms are going to work. And the problem is going to be the black box that comes along with it. That many of these learning algorithms, the deep learning, the neural networks, you don't know what's happening inside. And there is the attribution problem. But having said that, let me get Kalyan into this, and we can come back. We have time, a few more minutes for discussion. Kalyan, you want to take this? So how do you think this is all going to end up?
So we have to always strive to have the perfect, solutions. The perfect solution is a patient comes to me, I do a blood test. Within 10 seconds, I get the answer. This patient is going to respond to this particular drug the best. So that is the ideal goal. So how do we, are we going to reach that ever? So I think the only way forward is genetic testing, quick genetic testing, reliable genetic testing based on a big data of the patients that we are treating. That I think will be the final answer. We don't have that at the moment, but efforts are afoot towards it. We don't have the answer towards that for that yet. But short of that, we don't have any other option but to use multifactorial pathophysiological based approach.
Can I supplement this with a question?
Yeah.
So we've had Jeeva's. Yes.
Just a second before I. So I think the other, because there are few other things which are there. So when I've seen some of my colleagues, when somebody has got comes with a very high blood sugar level, and they check C-peptide level, and that's suppressed, doesn't mean that the patient has stopped making insulin. It's a glucotoxic toxic state. After giving medications, things settle down. You check the C-peptide, it will have gone up again. So it all differs at the time of diagnosis, and after 3 months of the diagnosis, things might be different. So it's a fluid state, as I said. It's not beta cell death, but it might be beta cell differentiation. Yeah, sorry. Yes, carry on, Krishna.
So we've had Jeevas now for, we've sequenced the human genome. We've had Jeevas, but we know that it's much more, that most of the changes that we have inherited are probably not even genetic, they're epigenetic, isn't it? And do you think that and a lot of physicians don't rely just on, data, they also rely on intuition, right? Yeah. So how do you think we are going to provide clinical decision support to compensate for the intuition that clinicians have and they develop over a period of time?
Okay, so I think at this point of time, we use zero genetic data, and the rest 100% is our perception of how to deal with it by multi-pronged pathophysiological approach. A very slim, rapidly losing weight loss insulin, otherwise obese, then you use SGLT2, GLP-1 receptor agonist, etc., etc. But what I'm trying to say is, if this is zero, if we can make it bigger, and that forms a bigger pie, so about 70% of our decision based on this, and 30% would still be, as you rightly said, everything cannot be just genetic. There are environmental factors here, epigenetic factors here, so we still have to rely on them. But if we have a big chunk decided by the genetic bit and a significant chunk based on pathophysiology and the way patient approaches the newly diagnosed patient comes to us, then combining both of them, that will be the answer, I feel. But we are far away from it. I don't think I will be able to see it in my lifetime.
Anjana, you are probably the person who's going to see it in her lifetime.
So,
you're 16 now, or 16, 17? So
that way, maybe 16 is a good number. Yeah. Okay.
So
yeah.
Can I ask you a question? Yeah, please.
I was going to add on to what Sir was going to say, but if you want to ask something, to go ahead.
So you actually, no, it is just a build on what Kalyan's talked about. So you probably are at a place where all these things are happening.
Yeah.
There is work on data that is going on genetics that is going on, and epigenetics that's going on, and a huge clinical database.
Yeah.
So can you talk about your plans to bring things together? Do you expect a clinical decision support that's coming out that based on all of these?
Yeah. So that's exactly what I was going to talk about, actually, sir. So there are three compartments, right? You said genetics. You said there's phenotype, physiological, data, that bit, and then there's this IT support. So there's three specific things you've done. Now, where are we today? We already have something from data, physiology. The clustering and all is based absolutely on physiological characteristics, phenotyping characteristics. So we've come to one point in which we have individuals based on physiology, based on phenotype. We've done some kind of characterization. We have done GWAS for all of these individuals. It's ongoing now. I do not have results at the moment, but in a couple of months, we will have GWAS data for all of these clustered individuals, sir. So I don't know whether we'll have good answers or anything, but the idea is that, like Sir said, the idea would be, and if there was something from the GWAS, from specific SNP signaling patterns, then it would be like patient walks in, you do something like a finger stick, you put it on a genetic strip, and that genetic strip tells you what this person's risk of, microvascular, etc., which drug will metformin work for this patient, will DPP-4. So all of these do have genetic signals. So the idea is to go that route. Whether we will have such clear answers, I have no idea at the moment. We've GWAS'd them. We don't have results yet from any of this. And then what happens? Something will throw up, even if we don't have, clear kind of line, something will throw up. And already you can see the beginnings of an app that can, phenotypically start differentiating. It's not very far away to a genotypic thing. There's also an artificial intelligence network in all of this that is built into the project that we're doing. So I do not know how long it will come, how long it will take, but I can tell you over time, this will come. This will come, and it will be not just for diabetes, but for just about everything. There's going to be this pathway wherein bloods come in, machine is telling you something, and it's guiding you towards. I also want to tell you something. So you mentioned something very clear about intuition and things. Now, it's my belief that intuition, it's coming from practice. It's coming from long built up practice over so many years. The generation of today doesn't have it anymore because they're not seeing patients the way people have seen for decades gone by. Everybody is relying on a machine already. Okay, people don't look at X-rays and MRIs the way it was done before. Everyone is relying on an ECG readout nowadays. So that intuition in the human being is getting less, and the reliance on the machine is already getting more. And this, in days to come, is going, as the machine gets more and more reliable, the human being's relationship with that machine is going to get more. So I feel and I fear that the only thing that's missing in this is the human empathy and emotion, whereas most of the decision support and the most of the thing can come in the future. And that is what I think it's heading to.
Okay, so the good news and the bad news is that Arvind just told me that we're going to continue this discussion for a while, and I hope you can stay back because Dr. Gabe is a little delayed, and he thinks that this discussion is so important that we should continue this. So I'm also asked him to come into it. Let Dr. Kulkarni. Arvind, you want to say just?
I just want to say that the same discussion is going on in both the halls, and then this is what we are going to do. The audience will see the same program in both the halls till 6:45. Dr. Gabe is held up in some very important meeting with the the governmental people. So he has sent. Is he
sending insulin to Afghanistan or what?
I don't know. So I think he will be delayed till 6:45 Indian time. So as soon as he comes, we'll start his program. But I think till then we can continue with this discussion.
Dr. Kulkarni, your point?
Yeah. If you go back to our pharmacology class, there was a group called as the slow acetylators and fast acetylators. You recall your second MBBS. Why not with the help of a specialty called as the bioinformatics and the genomic study and all the good clinicians of the country, we can identify the people who are DPP-4 responders, SGLT2 responders, or even metformin non-responders, sulfonylurea responders. It can be done, and I think we are neglecting a branch called as the bioinformatics and pharmacogenomics. If it is combined with institute like Dr. Anjana and Mohan and all other you people who are working at a big place, it can be done very nicely. The second question, what Anjana wrote was about the data security and data safety.
So can we come back to that in a minute? Yes, I just want to take this point and actually,
your flow. Take your flow.
So the question is this: if you look at the history of pharmacogenomics, right? I think 2014 is the watershed year, right? Till that point, we were doing single gene analysis of responses. But the truth is, and if you take metformin itself, as Dr. Kulkarni said, as an example, you will realize that the clinical differences are very different from single gene analysis of Kalyan. I can see your hand up. I'm coming in a minute. Your single gene analysis of metformin or DPP-4s. So, in fact, in my view, and I'll be very, and I'm being very provocative here, that pharmacogenomics has been a big disappointment in terms of the actual benefit in diabetes. It's very useful. For example, in Coumadin, or warfarin users, but in diabetes, very low. Because if you want to find somebody who's going to be a non-responder to metformin, you just have to give the drug for 2 months, and he's a non-responder. Or if he is going to develop a gastrointestinal side effect, and by the way, the pharmacogenomics are not able to predict it correctly, because if one gene is a problem, there is another pathway and another. So it's more than one gene that is involved. Kalyan, you want to comment about this? And I'll get everyone into this. I'm saying that pharmacogenomics, some of these proteomics and pharmacogenomics have not made a big impact on diabetes itself.
Yeah, so I was going to speak on those lines actually. So it is not just it's something apart from the genes, and most of it we don't know exactly. So as you rightly said, so for example, the incretin-based, GLP-1 receptor agonists, about 80% will drop their HbA1c and weight. And so about 75% will drop their HbA1c, 75% will drop their weight, and total of about, I think, 80%, 75% all will drop there. But what about the 25%? I've asked this question several times to basic scientists. So I said, can you give me animal data then to say that, okay, we can identify these animals will respond better to GLP-1 receptor agonists or incretin-based therapy or SGLT2 inhibitors? No answer yet. They have tried, but I think it's still we don't know that yet. And as Anjana had rightly said, that the previously using your brain to identify the patients, it reminds me of one study which was done in London to identify who is better, the London cab or is it the Google map. So they put two cars, one with a London cab driver in it, and another one with a Google app in it to go from place A to B. And the London cab didn't use the app, and the other one used the Google map. And guess who won? The London cab won, because he knew all the bylanes. He knew which roads were dug up and which roads had a bit of more of barricades, which had schools in it. At that particular time, the school students used to cross the road, so you're going to waste time there, although the Google map shows that is the way forward. So using your brain, read up, pathophysiology-based approach at this point of time, that's the way forward at this point of time. But I think if you are not going to have a very good experience, which unfortunately that's what Anjana said, and nowadays that's not the case, that the medical teaching, and then when you become a doctor, the amount of experience that you have, even in DM courses as well, you read a lot about endocrinology. My goodness, I mean, if I'll have a chap, he will speak volumes on, a thin Cushing syndrome. Now, why do you need to speak volumes about a thin Cushing syndrome? You're going to see once or maybe none in your lifetime. You're going to talk about 1001 endocrine issues, but the main thing plaguing us is diabetes, and you don't speak about that. So I think at this point of time, your point, Krishna, is that the genomics, it hasn't quite lived up to the mark so far. I completely agree with you. There are so many things missing in the diabetes picture yet, which we don't know. And that's what I said. I don't know if it will happen in my lifetime. Maybe somebody will just come up with all the answers, all the jigsaw pieces together, and we will solve it. But I don't see that happening very quickly. Sorry for the detailed response.
No, I want details.
It's really good. So it's really.
I mean, we hardly get to do this kind of talk. Yeah. Dr. Kulkarni, you have a comment on this. I'll come to technology in a minute. Any further comment on this before I ask Anjana to pitch in?
The common should be the first thing. And like you, I am also a teacher in MGM Medical College, Navi Mumbai, and the students they are not interested in touching the patient. They all want for their MCQs and their MDs, and I think after a few years, a general physician will be seen only in a museum, because there are 11 super specialists which are trying to encroach upon us. So the clinical assessment is most important, and I request Krishna, Sanjay, Arvind, all of you to come out a pan-India, simple, unified medical record for diabetic patients. One page, 50 point or 100 point. You come out with this, will help do a lot of research on that. We have got crores of patients of diabetes, and we are not coming out of good result. This is a mismatch between the talent and the data and the results.
Okay, so let me chip in one moment and say, the way I look at it is that our young people are actually better than us, right? They may not be able to palpate the tip of a spleen as well as our professors, yes, but they also factor in a lot more information than all of us put together, right? They are able to use new technology. They're able to handle patients far more better. And after all, the next generation should be better than the previous one, isn't it? While we can be nostalgic about the previous generation, I think the true success of the previous generation is a better next generation that provides more compassionate care to the doctors, to patients, and I think that's one part of it. But let me close with one sentence from each of you, and I'll start from the youngest. What is the one thing, based on all the stuff we've talked about today, that you think should be part of a clinician's armamentarium when they come out? What should they be able to do better than what we are able to do today?
So did you mean specific for diabetes or just overall?
We talked about three things today. We talked about pathophysiology, we talked about technology, we also talked about data, right? We talked about three things. And you think how much of this, or at least how much of the skill to do this, should be part of the medical curriculum or the postgraduate curriculum, or part of the next generation's training programs?
So if you ask me, I think you need all three. Okay, technology is definitely high up on the list because that's where things are going. It is not a part of the training right now, and I think it should be. What we already have is physiology. Pathophysiology is already a part of it. We still need it. We can't get rid of it. We still need it. So we need a little of everything. But there's no choosing one because we need them all.
Dr. Kulkarni, you have one sentence on this or two sentences on this?
All peripheral attachable devices with the proper data evaluation. Means activity tracker, glucose monitoring, whether it is a CGMS or whether it is a smart glucometer, and then tailor-made therapy. That will be the answer for everything.
Kalyan, last word to you.
Okay, so two aspects. So this I try and practice in my daily, when I see the patients. So one is I try to make up my mind what's the best drug or group of drug for this patient based on the history that he has told me. Second, when do I get the time to decide this? When I ask the second question is, what are the two most common ailments ailing? What are the two most common problems ailing you right now? Because, once I ask the patient, which is the most important medicine for you, he painstakingly brought out the bottle of Dufalac, because for him, that was the main problem. You talk about genomics and SGLT2. I am worried about my constipation. That's why I've come to you. It doesn't matter whether the high sugar has caused it or not. So what are the two problems which is bothering you? While he tries to think about and answer it, I'm thinking on the other side, based on what I've seen and the results, what's the best agent or group of agents to help this person?
So with that, I know why we will never reach singularity.
Yeah, with enough,
right? Because we would have confused techniques so much that we will never
breaking up. We can't hear you, sir. What did you say?
I said the reason we will never reach singularity is because we would have confused.
Whichever machine learning algorithm is there. We would have confused what?
The algorithm.
Oh, we would have confused. We're so good at that.
See, that is the grand plan. It's a grand plan to make
sure we don't allow the algorithm to succeed.
That's the grand plan to say that we stay in business.
I think Krishna.
With that, and thank you so much. It has been such a refreshing discussion. We have agreed to disagree on so many things that it's wonderful. Thank you so much, really.
Thank you very much.
Thank you for opportunity. And Krishna, we are reading your book, the modified teaching system. We are following you.
Oh yes,
you are a big
that's my imposition on the nation.
Yeah.
Pleasure to be here as always.
For all of us.
Thank you, Anjana. Thank you, Kalyan, and thank you, Dr.
Kalyan. Thanks.
Okay,
very nice inputs and really very practical suggestions. Thank you. Thank you, Sanjay.
Thank you, sir.
Thank you. Thank you, everybody.
Yeah.
Stay safe.
Yeah.